So we'll give a final 10 seconds for everyone out getting food. Better day, I think, now than we've had in the past. Everyone feeling better? I know the last 3 weeks were particularly difficult for me. Good? Okay, I'm going to start on time, and so thanks everyone for joining. As you know, this is the 2018 Ankylosing Spondylitis Patient Forum, brought to you by Canadian Spondylitis Association and SPARCC, Spondyloarthritis Research Consortium of Canada. So I'm going to try to make this a little bit interactive. So we also have people online, so the webcast, welcome. And I think you can be active limitedly, but do your best to be active. So we're coming here from Toronto, Ontario. And this is last year's picture of us. A lot of us. Comments? A little bit of housekeeping stuff. So my iris is a little bit blurry. So the salmon sheets, they're opportunity for you to ask questions. So look around for the volunteers that are around wearing the name tags from either CSA or SPARCC and hand them throughout the question, and then they'll be kind of sorted and prioritized and evenly distributed to the panelists. The yellow sheet is an evaluation sheet. If you don't fill that out, then we can't get any better. And I think we've done better this year than we did last year, so that was because of the evaluation sheets. So please complete those. I think everyone got on their chairs a support group flyer for the local Toronto support group. So if you're interested in that, they get together, I believe it's every month. The event is being videotaped and live streamed. So it's going to be focused on the speakers at the podium, and the audio will be recorded. So it shouldn't capture many of you in the audience. Certainly not anything that could put you in any type of trouble. The video event will be available on both the SPARCC and Spondylitis website. Please respect the room and manage your garbage. I think everyone knows they're in the back, those things, so take everything with you. Otherwise, there's going to be some people here with a late night. Refreshments will only be available until 7, so when we break, grab them from there. I think the doors are going to be open, and then we can get some air in here. Washrooms, I think everyone's aware where they're located, around the corner to the left. Also, the entrance doors there and by Second Cup will be locked at 7 o'clock. So if you have to run out, make sure you have a buddy to let you back in. And put all your phones on mute if you don't mind. Anything glaring that I missed, Maria? Thank you. I got the thumbs up from Maria. Okay, and this is a big thank you to our experts. I don't know if everyone here recognizes how talented and how well respected this lineup is today. I'm pretty impressed. What we've actually done is we've put in an element of pain management and mental health because you all told us that on the survey that you filled out. If you filled it out for the CSA survey in 2018, and the top 2 complications reported were chronic pain and mental health. So we're going to address that. Outside of this, I mean, we'll get into the introductions of the speakers, and then we also have Wendy Gerhardt. Where are you, Wendy? She's probably in the back making things happen. So she's our executive director, and she's kind of been helping to set up and organize all this stuff. And we all know that Maria usually is the one running the show. And we also have many volunteers, both from the CSA and SPARCC and UHN, to help with that. So thank you. Here are our sponsors. And now we're going to do a little bit of interacting stuff. And I'm going to try to get a count. So when you hold your hands up, if you're here with someone else, both of you put your hands up. So meaning, in my case, I would put my hand up, my wife would put my hand up, my daughter would put my hand up, her hand up too. But so that we can get a kind of an accurate count on how people are feeling about certain things. So how many before today were aware of the Canadian Spondylitis Association? Okay, so I'm calling that about 70%. Okay, 70, 75%. Are you a member of the CSA website? Okay, so we can do better here, right? We all have internet, I think, by now. Lots of good resources out there online, so please, I want some uptick here. The bigger we become, the more voice we have, the more things that we can get done. It's plain and simple. So if you're here supporting here, then support in all your different, everyone does it, right? Facebook group, okay. So about the same maybe as online. So some people just don't like being online. I'd call that 15% at best. And Twitter should drop down considerably to 5%. 5%, Wendy. Okay, so now I have to kind of tell you exactly about what we're all about. But we are national, and I want to save time. The shorter I am, the longer everyone else can be, and the longer your questions can be. But we're all across Canada. We do lots of good things. We talk with lots of good groups. We're a not-for-profit corporation since 2008. I mean, you can see this. We have 9 volunteers living with some type of spondyloarthritis disease and or caregivers on our board. And our executive director, Wendy, keeps everything spinning. And this is just kind of outlining the different types of education and advocacy work that we do, including this forum and forums across the country, the support groups, the Twitter campaigns. We did Psoriatic Arthritis Day not too long ago, and a bunch of other, I mean, we just did Pain Awareness Week. So we're getting out there, and I'll show you the growth as a result of that later. Okay, so here's growth. I mean, everything looks great and everything looks to be increased, but the truth is we just finished compiling all the stats, and some of them we don't know exactly what they mean, but this is giving an indication that we're building momentum. So what I do know is our public Facebook page, that's the page that kind of goes out to everyone. That's where we find new members to come in. So that's growing at 200% year over year from last year. The private Facebook page is kind of where all of the people affected with spondyloarthritis kind of group in together, and it's closed to everyone else. And that makes sense that it's growing at 34%, not as much. Then we have reach, which means you just pump things out and how many times do you get to people. And that's growing because we're sending more and more out. We're getting more engagement as a result. 77% increased engagement is excellent. That's where we get feedback from you so that we can put into programs like this. Twitter followers up, tweet impressions up. It just means the same thing, different platform. And then our website, we've got a little bit of work to do, but we're growing still. The number of sessions are starting to pop up in our session duration time. We're keeping people there a little bit longer. But much work to be done still here, but what this is saying is momentum. And the funny thing about momentum is it just, when it spins, it's like mental health. It just goes out of control. So we'll wait for the good thing about that on that, but we'll wait for the mental health spinning later. This is a pretty important message, why participate in surveys. Spondyloarthritis and ankylosing spondylitis in particular is so complex, we need all the help we can get. We often talk about pain and what to do with pain. Well, fill out a survey. It distracts you from the pain for a period of time. Pay it forward. Be part of the solution. The stuff that we participate and gather as part of surveys now are going to affect not only us until the end of time, but everyone else that's coming in before us. I look at myself at 46 years old, and when this disease started kicking in at, say, 14, if I had the stuff that was available now, I don't think I would be in the situation I am in now. So let's pay it forward. Results of surveys can help gather support programs specific to your needs. We can use this from large populations. It's very rich. I mean, I've been weeks and weeks and weeks looking at this data, and I'm going to show you some of the results. And there's some more additional reasons that I'll talk about too. This is kind of what we did on the survey. I think a lot of people would kind of understand this, but In 2018, early 2018, we launched this survey. We got 406 respondents. Most of us are AS. I mean, we've got to do a little bit about changing the makeup of this organization, but we need more people representing the other groups within spondyloarthritis. Lots of women like to participate, men not so much. Chronic pain and mental health both reported in over 50% of respondents and are the top 2 complications reported by everyone. Also, 52 people within this population have reported having multiple SBA conditions, which means, I mean, there's a lot of them with AS and PSA. There's a direct link to mental health and increased reporting of chronic pain, chronic fatigue, and sleep disorder. So, pretty important stuff, and that's why we're going to talk about it today. Here's a quick slides on really the different complications that were reported, so you can see the list there. We haven't captured everything. There's certain things that we missed, but if we missed it, we gave people the opportunity to free-form it in. So if we captured that and it actually was a complication that kind of related to this disease in some way, then we captured it. But that's pretty telling. People talk about ankylosing spondylitis. They talk about eyes, skin, and gut a lot. That's what I've been told over the years, but I mean, we're reporting that pain and mental health and sleep and fatigue are issues, big issues. So what came first? 44% of people reported having symptoms of a comorbidity first, before their SPA diagnosis. Why does this matter? Because other specialists need to be involved, and they need to understand how to recognize this and send people this way. So this is what we captured from the respondents that other specialists are suggesting, but these percentages should be more. Chronic pain and mental health. 62% of people with chronic pain reported having mental health issues. 42% of those without chronic pain reported having. So there's a 20% increase of mental health issues when pain's involved. And 54% of the entire population reported having mental health issues. It just gives you the difference. Non-pharmacological therapy we looked at, and you can see it all there, what people are doing, what they're using. And we'll touch on some of these later. AS and treatment options. 45% reported using a biologic, 2% reported using a biosimilar, 86% NSAIDs, 24% DMARDs, and 21% medical cannabis. Interesting? Hope so. And then my last question here, I think, is how many here have actually completed the international AS survey? Okay, so I think we're hovering at 2%. So this is a challenge to everyone, please. I think we're somewhere in the range of 300, 350. I think Spain or one of these countries may have been the most at about 700, and we kind of should beat them. So please, you have the sheet on your thing. Take it home. Please fill it out if you qualify for this. And I've seen the results out of Spain, and they're fantastic. I've seen the video, and it speaks to patients. It gives a lot of, I mean, there's a lot of little answers in there that sometimes patients, the medications may not work, the therapies may not work, but sometimes when you hear something and it's explained to you and you know that other people are dealing with it, then sometimes that just magically helps. So the information for this is on the website. Please, as you're becoming a member and joining Facebook, click on the link to fill out the survey and get that done as well. I'd really appreciate it. That's kind of why we do things here. And this is what it looks like. We've talked a little bit about local support groups and community support groups. So I think the ones in italics are the ones that are, I mean, I can't even, they all look blurry to me, Wendy. So Toronto, Hamilton are running, Ottawa is running, and I believe are the rest of them kind of getting formed? Yeah. So the deal that we have with all of you on support groups is if you are interested in starting up a support group in your region, we'll support you. We'll give you the playbook and we'll support you, and we'll get advertising out to people, but you need to be actually taking charge and doing it yourself. So that's the deal that we have, and we're not doing too bad now across the country. And the other thing too is, I mean, to keep this thing running and to keep fighting for people that live with our condition, we need volunteers. Oftentimes we work as fast as we can work with the volunteers that we have. So we're a little bit more organized now, and I think that we'll be better able to start transitioning some of these volunteers. So if you have a set skill and you're specifically passionate about it, i.e. web design, social media, any of those types of skills and passion, we'd like to put them to use. So I heard your introduction of Susan today, and I mean, I can't believe you remember all that stuff, but nothing about your schooling or whatever. I've known you for, it's got to be 10, 12 years or so. This man changes lives. He's my rheumatologist, and I think most of you all know him here, and this is the reason that we're all here, is because he puts these things and he cares. So he's going to come up and talk to us about what's new with AS. Thank you.
Thanks, Gerald. I did most of my training in the States. When I came back to Toronto, there was a small organization called the Ontario Spondylitis Association. There's one in BC too. And when this Spondyloarthritis Research Consortium of Canada, SPARCC, got born, there was a vision that really on the part of the rheumatologist and the patients that we really could work together more effectively. And it's just fantastic work that you and Wendy have done. It's very exciting to see this all coming together. It's really great. I'm going to, let's see if I've got, I think I'm preloaded here, I assume. Did you, Marie, I sent this, oh, here we go, okay, we got it here. So I'm the little preamble for Dr. Haroon, who's coming next to talk about the new treatments, but I'm going to talk, just give you a little snapshot of some of the issues that we're dealing with at the moment. Here we go. Back pain, no matter what profession you've got, having a functional back, whether you're reaping out in the fields, having a pain-free range of motion in the back is an important part of life. So that's the dominant issue, and this data actually comes from a survey that we did several years ago, actually with the Spondylitis Association of America, our sister partner organization in the US, about just the peak age of onset. This is interesting. It's a different curve than you'd see, say, in rheumatoid arthritis. Interestingly, that under 18 group, where patients are having their first symptoms, either in the back or peripheral joints, like hands and feet, it's about 18% of our clinic. So these are young kids in high school who are starting with back pain. Usually their parents assume it's a sports injury. They switch their skates or they switch their sport. And finally somebody circuitously gets them to see a rheumatologist. So they actually start off in the high school years, and then when they get to about 16 or 17, they get kicked out of hospital for sick children, and they come over to see us. So it's quite a spread, and even some older patients too. But these are the most productive parts of a person's life, of course, and what we hear, picking up on some of the themes for tonight, is that in this age bracket from 18 to 30 are when people are deciding their careers, they're deciding graduate school, and they're deciding their spouses, and major life decisions are going on, and they're being impacted by this chronic disease. So that's heightens the sense of urgency and the timeliness of our intervention. This actually reproduces, the Canadian data is actually better than this, but this reminds us the dominant features that Gerald just highlighted very nicely with we're very excited about the Canadian survey. A couple of points of reference there. You can see, as Gerald mentioned, sometimes the first pickup is with the ophthalmologist with an episode of iritis or uveitis. And a lot of our ophthalmology community now are getting increasingly aware of AS and when to do a B27, when to refer. So that's very helpful. And if it's the first initiating event might be bowel inflammation like Crohn's disease or ulcerative colitis. And the same thing, we're trying to, with these experts in other disciplines, ophthalmology, dermatology, gastroenterology, trying to facilitate this recognition and these referrals. The sternal pain, I'll just make a comment there. I'm sure somebody in this room has experienced what we call anterior chest wall pain. This is we usually think of AS as affecting the low back, but when it affects the chest wall, it can be quite distressing, and it can be quite confusing. If a patient arrives in the emergency room with chest wall pain, thinking they may be having a heart attack, and it's actually their spondylitis. So it's a major issue. We participated in something called the ASAS Health Index that's generated. It's a multinational set of indices that used a very large database, the International Spondylitis Association, to really look at some of the major impacts of daily life. So that you'll see terminology that the ASAS Health Index used in some of the surveys that are now circulating. It's very helpful. But you can see here just about every aspect in this particular, our initial questionnaire, every aspect of daily life, the things that kind of bring us joy and fun and distraction are impacted by ankylosing spondylitis. And it's significant, and it's, as we'll hear shortly from Susan, that the major impact on psychosocial adaptation is a huge issue. And we can see here, in fact, that you look at these major impacts. So whether as physicians, as rheumatologists, we tend, since our training is in looking at the biology and the physical aspect of the disease, we tend to see the disease through that lens. But we've learned from you that's too narrow a focus. We know now that just about the emotional and social impact of this disease is immense, as everyone in this room knows better than we do. When you look at these, how the health policy planners, this is international coding of disease, how you actually kind of comprehensively capture something like this. When it's something that starts with a local, maybe some T cells infiltrating the sacroiliac joint, but they affect your employability. Like you've got these different domains in this universe because it's affecting every aspect of life. So you can see that this is from the WHO, but they try to capture disease comprehensively because the biologist will look at one quadrant. It's the blind man and the elephant, right? The rheumatologist might be looking at joint inflammation. The psychologist will be looking at adaptation. The physiotherapist will be scaling their exercise. But at the center of all that complicated equation is the patient, and the patient struggling with the disease and trying to carry on as best they can. And all these contextual factors figure into it. So this is a great... We need machine modeling. I'm not ready for artificial intelligence. I'm just struggling with endogenous intelligence before I get artificial intelligence. But you can actually see that as we get more sophisticated in our data analysis, we can actually aggregate some of these very different domains, like the cytokine level and emotional well-being, and how exercise influences the immune system. Domains that we would usually think of as being disparate actually all come together. They come together in the patient. Now this is a slide, this actually from our survey originally with the Spondylitis Association American. We still see this slide as a bit of an indictment of ourselves as leaders in this field. So we asked the question, so how long was it from the onset of your symptoms to the time you had a diagnosis made? So if you take the 50% cut there, like the lower two quadrants of this circle, you can see that at least 50% of patients had 6 years of symptoms before the diagnosis was made. Now, if you did that in rheumatoid arthritis, that would be totally unacceptable. You'd say, wait a sec, you had 6 years of painful swelling in your joints and nobody made a diagnosis? Or they said, well, nobody got around to doing an x-ray. So it raises a lot of very important questions on the rheumatology side about the diagnostic or the classification criteria, but there's something this is a challenge, right? Because I'm sure many people in this room, and we hear it in the clinic all the time, before they finally got to a rheumatologist, they were seeing a physiotherapist and a psychiatrist and an acupuncturist and herbologist and a naturopath, and finally somebody said, maybe your inflammation in your eyes got something to do with your back pain. And they started to put the pieces together. So the reason I say this is a challenge for us is this battle really is not fought amongst the rheumatologists, it's in primary care physicians. It's sports clinics, it's physiotherapists, it's the healthcare practitioners that are actually seeing young people with back pain. That's where we really need to far more effectively communicate and at least raise the level of awareness. And this affects long-term outcome. As Dr. Haroon will say, there's evidence that the earlier diagnosis leads to early intervention, leads to better outcomes. And so we can see here that this is not just somebody struggling along with unexplained joint symptoms, it's actually going to affect long-term outcomes. So there's a sense of urgency, and I think very much we feel that on the rheumatology side, working with the CSA, this is really a joint effort because we're mutually invested in improving these data. Now, one of the challenges with, I use rheumatoid arthritis as a contrast because a patient that appears at a busy general practitioner's office with swelling in the small joints of the fingers, if the GP misses the diagnosis that day, they'll probably be back 2 weeks later saying, you know, I can't get my rings on, right? Maybe I should see a rheumatologist. That same patient with low back pain, the GP may say, well, we'll get you into some physiotherapy, take some NSAIDs, we'll see you back in 6 months. There's not much to really, in terms of the physical examination, there's not really much to help that GP to discriminate. And the problem here is that back pain is so prevalent in the population. And so the busy GP is seeing a lot of patients with coming, it's probably the 2/3 of patients are musculoskeletal, seeing a GP, and back pain is a dominant reason for people to see their doctors. So there's a lot of background there. So what we've been trying to work with, and this is with ASAS and the CSA and SPARCC, is how do we actually raise the index of suspicion appropriately? So these are some of the kind of grids on our side of the street that we work with. So a younger patient with back pain, not to say that, as you saw, AS can be actually diagnosed in the 50s, but we're looking at younger patients with at least 3 months of back pain, sustained back pain. So if we begin to introduce that level of awareness of suspicion, you see, if a GP or a physiotherapist or a sports physician is seeing a young patient with chronic back pain, this should register. And then those who have been through our clinic many times, we use these indicators that might shift the probability away from what we call mechanical back pain to more inflammatory back pain, as from, say, disc-related problems to ankylosing spondylitis. And some of these features you would know well. Morning stiffness, for example. Laura and I saw a patient recently in the screening clinic, and it was so striking. It was a young guy, 26 years old, with a year of back pain, and it really took him an hour to get going in the morning. Like, it was really striking, and bingo, he had diagnostic changes on a sacroiliac joint after even just a year of symptoms. So we use these variables. None is completely diagnostic. They just shift the probability. So these are the questions that ideally we'd like our GPs to be conversant in these. Now, besides the characteristic of the back pain, and when we're talking to our family practice residents or our medical students, we would alert them to, if you see anything else going on besides the back pain, that changes the equation. So is there arthritis in the joints, like knees, feet? Is there Achilles tendonitis, or what we call enthesitis, or heel pain? Is there any evidence of swollen digits, dactylitis? So it mandates a good physical examination. We teach our medical residents and our medical students to always look not just at the back pain, but look at the whole patient. Imaging is important. I'll talk about that in a second. And as you're aware that we use a lot of imaging in our clinic modality. Sedimentation rate and CRP, you're probably familiar with those terms. They're totally nonspecific. If you slipped on the ice coming into the clinic, or you had the flu last week, they're going to be up for other reasons. So they're neither specific nor sensitive. And yet, we don't have any cool autoantibodies like our lupus friends have got, but that's the best. The response to NSAIDs is interesting because it's not unusual that a GP would at least start somebody on Motrin or Advil or naproxen to get started on the back pain. And sometimes the degree of improvement in back pain can be a surrogate marker for how much inflammation is going on. B27 is present in about 80 to 85% of our patients, and a family history is very informative too. Not just of spondylitis, but do you have any family members with Crohn's disease or iritis or psoriasis? They all cluster together genetically and clinically. Predisposing factors, well, we have an interest in we have several patients in our clinic whose spondylitis clearly started with an infection. They went abroad, they got a gastrointestinal infection, and they had what's called reactive arthritis, and then over time that seems to evolve into AS. So in terms of the research agendas, there's a great deal of interest on both clinical and basic science about what the nature of that trigger is. What kind of infection can actually start this process to begin with? We certainly recognize that HLA-B27, if somebody develops an arthritis after, say, a gastrointestinal infection, the likelihood of it going on to a chronic arthritis is tremendously increased if they've got this particular HLA-B27. And then psoriasis, Crohn's disease, and uveitis, as Gerald just mentioned, these are kind of their classical features. And so we would certainly try to alert general practitioners and physiotherapists that if they're taking a history, a young person with back pain, if they've got any of these features, all of a sudden the light should go on, right, for a referral to rheumatology. I mentioned the fact that our physical examination lacks some of the sensitivity that in, say, when you've got small joint inflammation, like in rheumatoid arthritis. Everybody's done these in our clinic. We're really big on measuring back mobility. But if you went out to the airport and lifted up your suitcases tonight and got a back strain, and we brought you into the clinic and had you do this back mobility, it would be very restricted. So you could have restriction in back pain and back mobility for other reasons than just spondylitis. But in an established AS population, we do use it as a marker, these measurements of progression over time. And then, of course, lateral spinal flexion as well. The presence of iritis. And as I mentioned, we have close connections with the ophthalmology community in Toronto because we referring to them and they referring to us when there's complications. This is a significant issue. I'm sure, well, statistically, 33% of the people in this room would have had uveitis. Happily, if it's treated aggressively with topical steroids, Predford, it can get under control nicely, but it can lead to secondary glaucoma and cataract formation. Enthesitis, I mentioned, significant issue in some of our patients. So X-rays forming a really important part of our diagnostic assessment, probably much more so than, say, rheumatoid arthritis and certainly lupus, because the X-ray changes of spondylitis are really quite distinctive when they're there. So we see for somebody in the spine, and the real hallmark are these bone spurs, right? So the bone spur, which we call syndesmophytes. So under normal circumstances, what allows our spines to move normally in a pain-free way is these intervertebral discs have flexibility. But if you throw a little bone bridge across the disc there, where that arrow is, instead of a pain-free range of motion, it's getting restricted, right? So that's a very distinctive picture for ankylosing spondylitis. That's what we're out to. So one of the questions is, can't we do better in making a diagnosis earlier by earlier referral? So this anticipates, Laura's going to come up shortly talking about the importance of exercise. I'm probably stealing your thunder, but no, she's okay. Thumbs up. So this is recognizing there's an issue. There's a challenge in early recognition of AS. Particularly now that we have good effective treatments, how do we actually do better? So Laura's actually taken a really important lead in this, and we realize that with the prevalence of back pain and the number of rheumatologists in Canada, which is about 360, we really don't have the bandwidth to cope with this. We have to have a better strategy for early identification of patients. So Laura's taken the lead with Dr. Raj Ramprasad here at Toronto Western on a screening program that evaluates back pain at the population level. So we have 3 nodes in this study: Thunder Bay, Hamilton, and Toronto. So the intake is not the physician. The intake either comes through, it's not a rheumatologist. The intake comes from GPs or from chiropractors into physiotherapists and trained chiropractors that are familiar with AS. And the idea really is to create a far more effective triage system, what we call the spondylitis screening clinic. It's a work in progress. It's great. We're trying to clone this across Canada. Some of these people have trained with us, and our best model, working with the CSA, would be to have a rheumatology champion and a physiotherapy champion in each site, so we can actually do better on this. And then so that's really models of care. It's a healthcare quality issue. The other issue is, how about in the clinic? Can we do better imaging? Well, one of the challenges here has changed everything is the presence of MRI. So this is a typical MRI. That little white spot there represents inflammation, or what we call bone marrow edema. That's called a stir sequence, and many people in this room have had the joy of sitting in an MRI for an hour. It's kind of creepy, I'm sure. I've done it. But that is really quite distinctive. So the MRI has turned out to be very important. When the x-rays are non-diagnostic, the MRI can really help us significantly. And so it's led to this kind of model. So we've got ankylosing spondylitis. That's the New York criteria. They were established back in 1994. Still pretty much the gold standard for most clinical trials in genetics. By that time, we've got distinctive changes in the sacroiliac joints. So these blurred changes in the sacroiliac joint are very distinctive. But that timeline is lengthy, you know. So for example, we don't rate for damage to occur to a joint to make a diagnosis of rheumatoid arthritis. So why would we wait until there's damage to the spine? So that's where the MRI has really been helpful. So we have this rather bulky term. From ankylosing spondylitis, we get that. But now we've got this crazy term, non-radiographic axial spondyloarthritis. Can repeat after me. I mean, that's a very, not only, it's a bulky term, it's not a really great term. Even from the government and the insurance company industry point of view, what is non-radiographic axial spondyloarthritis? Now, some of these people, our people in the room here know what it is. They've got all the symptoms. They're B27 positive, but their x-rays are non-diagnostic, but the MRI points out they've got inflammation. So we have no modalities now, at least to be able to detect the disease earlier. And we think that obviously this timeline where you go from an MRI that's positive in the back to an x-rays that's showing changes to actually the bony bridges, the syndesmophytes. We really want to stop this timeline before we move too far down the pathway. So it's kind of if you look at the back pain population in the province of Ontario, incidentally in Dr. Haroon's study in the cardiac complications, it was the survey in ISIS database, about 24,000 AS patients in the database of ISIS. If you look at how it evolves, so there's a sort of a heterogeneity or variability in the course of this disease. So you could start up here with, we're not quite sure, if somebody just presents to a GP with inflammatory back pain, some will probably go into spontaneous remission or respond to NSAIDs. They've never seen a rheumatologist. They're doing fine with their physio and their NSAIDs. Some will then follow into a more quiescent category. This has been an issue with the natural history of this non-radiographic form, like how many actually, do they need to be on biologics? Do they need to be on NSAIDs? Some evolve over time into late complications. Some go into a pathway that is really non-progressing. So a lot of what we do in our clinic, our team does, is actually, at the moment, that's very descriptive longitudinal data. But if we have a young person in their 20s up there upstream, are there genetic markers or serum biomarkers or clinical characteristics that actually can allow us to prognosticate more accurately? So that's a lot of, I know it's tiresome to do the questionnaires in our clinic, but this is sort of what the strategy has been. So we're trying to work with this, again, working with the people that see back pain on the front lines. What constitutes the best screening mechanism? The most cost-effective with the least false positives and the least false negatives. And this is going on. And so algorithms like this come on. So if we're talking to a group of family practice residents, to alert them if you see a young patient with back pain, how do you actually start? Because often the first x-ray is not even the appropriate x-ray. They may do a lateral lumbar spine when in fact we need to look at the sacroiliac joints. So this is a solvable problem. We believe it. We're working on it. It's an education challenge for us. I think we're up to it. SPARCC runs annual resident research and education days. So we get all the rheumatology residents from all the training programs in Canada come to Toronto for an intensive day and a half of x-rays, labs, physical examination. We really try to concentrate that. Genetic factors are important. These are two twins from the Philippines. Their x-rays are exactly the same. They're both HLA B27 positive identical twins. Their x-rays are indistinguishable. They actually have had both hips replaced. HLA B27 is a very important marker. And wherever you go in the globe, if there's a lower frequency of this gene, there's a much lower frequency of ankylosing spondylitis. It kind of tracks around all ethnic and racial groups, this gene seems to still have a dominant susceptibility effect on ankylosing spondylitis. This is what's called the Manhattan plot, where basically the geneticists screen our whole genome to see which genes are actually associated with spondylitis. And the big tall tower there is B27. HLA-B27 is the dominant genetic element. It's called a Manhattan plot because somebody thought it looked like the Manhattan skyline. We actually think in rheumatology, we think of it this way, right? It's actually the Toronto's plot, all right? So every time a spondylitis expert looks at the Toronto skyline, they see this big B27 effect. So, and just to wrap up, it's not just genes. So having B27, and 85% of patients with AS have the gene, but if you've got the gene, only 2% of patients will have ankylosing spondylitis. So it has both sensitive, but actually fairly poor sensitivity. So the issue is, what else is going on? If there's so many people out there with this gene but don't have AS, so that gets us into the issue we just talked about infection, triggers. Somehow the genes set the stage. There's something provocative, almost certainly other genes acting in concert, but environmental factors. And we believe that, for example, infectious triggers, diet, the microbial population in your gut, the so-called the gut microbiome, is a big thing. So research in AS, just to finish up, covers many things. It goes all the way from sequencing DNA molecules to looking to see how B27 affects cell biology. But ultimately, we're really looking at how it affects the disease, and not only the patient population, but the population at large. So it runs really all the way from molecular biology to population health and clinical epidemiology, and a lot in between. So it's a multidisciplinary disease, which calls for a multidisciplinary approach, and this is some of our team. You can see that it does include epidemiology and physiotherapy, surgery for sure, pharmacology, and happily we're part of an international network. So we've actually these are just some of our international fellows that have trained with us and gone back with the message, gone back with the gospel to take the message of early detection of ankylosing spondylitis to their home countries. Okay, so I think we're going to skip over to Dr. Haroon. So just to introduce Dr. Haroon, the co-director of the spondylitis program at Toronto Western Hospital. Actually, he's one of those maps. Dr. Haroon and I met at a medical conference in Lucknow in northern India. It turned out, besides our intrinsic attraction to ankylosing spondylitis, we really love dire straits. So we got into the car, we're driving around Lucknow, and Dr. Haroon puts on this tape of Dire Straits. I said, "Are you a Mark Knopfler fan?" I said, "We belong together." So Dr. Haroon came and did a PhD in Toronto, listening to Dire Straits in the lab most of the time, and has had a spectacular success and a huge contribution to spondylitis. Dr. Haroon.
Thank you very much for that kind of introduction. We're running a little bit late, so there are several data slides here. So I'm going to be talking about treatment of ankylosing spondylitis. What I've tried to do is try to concentrate more on the recent advances, because I know most of you have been coming year after year. So I've tried to do only recent advances, and then sort of leave with a few messages for you. Okay, so the goal of today's talk is to understand that there is a window of opportunity when treating ankylosing spondylitis patients. We have ACR's, the American College of Rheumatology has come up with recent recommendations. It's not yet published, but it was presented at a recent conference. So we'll just go through those recommendations to see what is new. We'll talk about the two major modalities of treatment, biologics, TNF inhibition, and IL-17 inhibition. We'll see the results. And finally, we'll stop with how we can modify this disease, what are the results, and approaches to do so. Okay, we'll start with a very simple slide here, right? Very easy to follow and understand. So the only thing which you want to be looking at is this box here, 81%. So that's the chance of responding to TNF inhibitor if you fall into this box. If you fall into this box, there's a 5% chance of responding to a TNF inhibitor. So now let's see what the characteristics of this box are. So they have they have low BAS-V score, which essentially means that they are more functional. Okay, they are much younger, and they have high markers of inflammation. They're likely to be HLA-B27, the gene. They're likely to be positive for that. Okay, so the most important thing which I want to mention from this is that they are much younger, and you could substitute this for the disease duration. So if you diagnose these patients with, say, less than 2 or 3 years of disease duration, you're much more likely to achieve remission with these drugs compared to somebody who is diagnosed at 10 years or later. Okay, and I'll just show you with couple of slides. These are the results from the original TNF inhibitor studies, and patients enrolled into these studies had around 15 years of disease on average. Okay, so these are the drugs which you're familiar with: infliximab, etanercept, adalimumab, golimumab. There is one more, certolizumab. All of them have almost similar results. And what is the result? A 40% improvement in symptoms at 6 months. Okay, 40% improvement in 6 months at 6 months in around 50% or less number of patients. So that's what the clinical trial shows from the original studies. Now let's compare that to this study. And if you look at any of the more recent studies, patients have been included at 3 years to 5 years of disease duration, and some even at 1.5 years. And just look at this column here. Partial remission, which means that you're essentially asymptomatic. It was very difficult to achieve a while ago in ankylosing spondylitis. So patients without any symptoms, more than 50%, and that too at 16 weeks of starting treatment. And the main difference is when the treatment was started, at 1 to 2 years versus 15 years. So clearly, the earlier you diagnose these patients and start treatment, the higher the likelihood of getting clinical remission. Now we move on to this study. This is a study with infliximab. Just as an example, this study was, the question we are asking in this study is, can we treat ankylosing spondylitis like we treat cancer? So come in strong initially rather than wait for a long period of time before starting the biologics. So these patients essentially had symptoms for less than 3 years. They had never even tried anti-inflammatory drugs. Okay, so they are randomized to 2 arms. Even before anti-inflammatories, they get infliximab straight away, a biologic, or they get an anti-inflammatory. And at 6 months, look how many people have gone into remission. And if they've gone into remission, then they're further randomized to, so the infliximab or the biologic is stopped there, and they're further randomized to receive either no treatment or they just continue on the anti-inflammatory. And further down, by end of 1 year, how many people are still in remission. So let's look at the first time point. You'll see here, 62% of people are in remission at 6 months with the biologic. Interestingly, 35% of people are in remission just on an anti-inflammatory. And this is quite close to what we have achieved even with the biologic in the previous studies. That shows that if you start early, even anti-inflammatories have a very good response rate, and much better if you start with the biologic. Okay? Now, what happens if these patients, you take off these drugs? Almost 50% of these patients remain in remission at the end of 1 year. So again, showing that if you diagnose these patients early, treat them aggressively, there is a higher chance of stopping the biologic at a future time point. So the chance of a drug-free remission is much higher if you diagnose and treat them early. Okay, so now we move on to the 2018 update of the American College of Rheumatology recommendations. So the main difference from the previous recommendation, which was, I believe, in the 2012-2013 period, is the addition of interleukin-17 inhibition. Okay, we'll come to that shortly. So if patients have active ankylosing spondylitis, whatever appears in green means strongly recommending favoring that treatment. Okay, whatever appears in red means you're strongly against that form of treatment. You'll see here anti-inflammatories. The first line of treatment is anti-inflammatories and physical therapy. Okay, what is in red? Steroids. So steroids may work for a short period of time, but you need very high doses, and you can't keep taking them forever. So it is strongly recommended against taking steroids like prednisone for a long period of time as a form of treatment for ankylosing spondylitis. But for a short period of time, if the situation demands. For example, in pregnancy, in the last phase of pregnancy, you cannot take anti-inflammatories. Maybe that's a period when you can take a short period of steroids. There may be a few other such situations. Okay, if patients have significant peripheral joint involvement, maybe we could add sulfasalazine, methotrexate, some of the drugs which you're aware of. They're taken orally. They have not yet reached the biologic. And if there is significant pain, and if it is restricted just to a joint, for example, sacroiliac joint, you can try injecting steroid locally into that particular joint. Okay? Now, if you've tried anti-inflammatories, in our clinic, around 25 to 30% of people need only anti-inflammatories. And they respond to that, they just keep taking that, that's fine. But the remaining number of patients, they need something stronger. And then the first line of treatment recommended by the American College of Rheumatology is a TNF inhibitor because of almost 20 years of experience with them. We know how safe they are, we know the side effect profile, and we know how to monitor them. So TNF inhibitors are usually the first line of treatment recommended. And if there is recurrent iritis, eye inflammation, or if there is inflammatory bowel disease, then specifically a monoclonal antibody is recommended. So there are two different kinds of TNF inhibitors, a monoclonal antibody and a receptor. So etanercept is a receptor. It has a different mechanism of action. It is not as effective for iritis and inflammatory bowel disease. So the other four are recommended if you have this particular condition and if it is active. Okay? If you still continue to have active ankylosing spondylitis, then you probably need to switch. Now, it depends on whether you responded to the first TNF inhibitor or not. If the patient has responded to the first TNF inhibitor, it means that the disease in that particular patient is likely TNF driven. So in that case, maybe we are losing the efficacy because the body is rejecting the TNF inhibitor that is being used. So maybe you can go to another TNF inhibitor. But if you start a TNF inhibitor and there is no response at all, then probably it is better to go to a different mechanism of action, that is the interleukin-17 inhibition. So TNF and interleukin-17, these are the two molecules that are currently considered to be important in driving inflammation in ankylosing spondylitis. So we have secukinumab, which is currently approved for treatment in ankylosing spondylitis, and that is the next step in treatment of ankylosing spondylitis. Okay, I think we can go on to, I already showed you the results of TNF inhibitors. Now I'll show you a few results of targeting interleukin-17. So we have several ways of targeting interleukin-17. So essentially, interleukin-17, there are different kinds of interleukin-17. They attach to the receptor for interleukin-17 and activates the immune cells in the body to create a lot of inflammation. So you're trying to block this interaction between the molecule and its receptor. You can do that either by blocking the molecule or by blocking the receptor. So secukinumab, which is currently in the market, blocks the molecule IL-17. Ixekizumab is the second molecule which has just been published in both biologic naive patients and also those who have failed a TNF inhibitor. I'll show you the results shortly. And then a third molecule which is approved for use in psoriasis and psoriatic arthritis is brodalumab, which actually blocks the receptor. So these are the two different mechanisms by which you can block interleukin-17. So for secukinumab, there are many studies that have been done on secukinumab, and they start with the term measure. I don't know why, but it's measure. So the measure 1 study, 2, 3, and 4 have been published so far. They're testing different situations. So measure 1 tested whether it's advantageous to have an intravenous loading dose. Measure 2 tested subcutaneous loading dose. Measure 3 tested if a higher dose of 300 milligram is beneficial than the currently approved dose of 150 milligram. And measure 4 tested without any loading dose at all. Okay, and this is in a nutshell what the results look like. They're almost similar to what you expect with a TNF inhibitor. So it's not that one is better than the other, almost similar results. It may be that in a particular patient, the disease is driven by TNF, then the TNF inhibitor is better for that patient. If it's driven by IL-17, then maybe IL-17 inhibitor is better. Unfortunately, we don't have a mechanism by which we can identify the best drug for that particular patient at baseline. So we're working on it. Hopefully, in the near future, we'll have some kind of algorithm in which we can do that, by which we can do that. Okay, this is the new drug, ixekizumab. Again, similar to secukinumab, blocking interleukin-17A. Two published studies so far, COAST-V and COAST-W. COAST-V is in patients who have never seen a biologic before, just straight after an anti-inflammatory. And COAST-W are people who have failed a TNF inhibitor. Interestingly, in this study, I think this is probably the first study where individuals who have failed even 2 TNF inhibitors were allowed into the study. So multiple TNF inhibitor failure yet allowed into the study. And the results are almost similar to what you would see with the secukinumab as well. There is a between 30 and 40% chance of responding by around 50% response in these patients, which is similar to what we have seen before. So these are the main results of the ixekizumab study. So here there are multiple arms in studying 80 milligram, 160 milligram, and the results are almost similar between the two doses. It was tried every 2 weeks and every 4 weeks. And this is just to show you the duration of the disease in this trial. It's not that different from the original TNF inhibitor studies, right? It's around 15 to 16 years of disease. So you should compare the results with the original trial, not with the new TNF inhibitor trials. And you see again 40% response in around 50% of patients. So that's what is practically what we are seeing with all the drugs that we have currently. Now, the interesting thing here is, if you have TNF inhibitor, fail a TNF inhibitor, there is still a significantly better chance of responding to this drug compared to a placebo. So again, good news, we have one more agent that we can use even if you have failed a previous biologic. Okay, so radiographic progression is one of the most important things apart from the inflammation and the symptoms in patients with ankylosing spondylitis. So this is an example of a patient who has gone on to progress to fusion. So initially there was just fusion in one discal vertebral segment here, vertebral unit here, and later on going on to fuse here. The good part of the story is that less than 20% of people actually go on to fuse like that. Okay, it's a very small percentage of patients who actually go on to fuse. The vast majority of patients don't have significant fusion. Now, in those 20%, is there something in our treatment modality that we can use to prevent this from happening? So the original studies were with anti-inflammatories. This was promising. So in this particular study, celecoxib was used on demand versus a group of patients who took it daily, twice a day. And at the end of 2 years, this was the rate of progression if you took it on demand, lower progression if it was taken every day. So it was sort of promising. We thought that, okay, maybe taking anti-inflammatories on a regular basis could be disease modifying. Now, after that more recently came this study. This was with the different anti-inflammatories. So it was again diclofenac continuous versus on demand, exactly like the previous study. You see here at baseline and 2-year follow-up, around 60 patients in each group completed the study, and you'll see that those patients who took daily diclofenac had almost double the amount of diclofenac compared to the other group, and these are the results. Essentially overlapping in most of the trajectory here, and there was no difference between those patients who were daily on an anti-inflammatory versus those who didn't take it. So the current state of understanding is that if you're doing well on a biologic, you don't need to keep taking an anti-inflammatory to prevent progression. But if you need it if you're symptomatic and need it, yes, the patient should be on regular anti-inflammatories rather than being on demand. So essentially, there is no disease-modifying potential for this drug. How about TNF inhibitors? So we did the first study actually looking at this in a large scale, looking at 5 centers across North America. We had around over 300 patients in this study. And based on our definition, around a third of patients progressed. Now the question is, are patients who were in this particular part of the pie chart, those who progressed, did they get less amount of TNF inhibitors compared to those who did not progress? Maybe TNF inhibitors are preventing them from progressing. So here is a chart looking at regression analysis when you add every factor in the patient together. I'll just highlight these two. If the patients had damage at baseline, they are more likely to progress. If there was evidence of inflammation, more likely to progress. Patients who smoked, much more likely to progress. And if the patients used TNF inhibitors, 50% lower risk of progression. So this was probably the first study to show that there's a significant benefit of using TNF inhibitors to prevent progression. And we did it in different ways. The statistical analysis, it gave exactly the same results, around 50% decrease in risk of progression. Again, going back to the window of opportunity question, we talked about starting early, better chance of remission. Starting early, better chance of stopping the drug in the future. Now, the results of this study show that if you start early, there's a much higher chance of preventing progression compared to when you start much later. So again, one more reason to start treatment earlier. So another way to look at this data is, so blue dots, each dot represents one patient. So the blue dots represent patients who started the drug after 10 years. The red dots represent patients who started the drug much earlier. You see that those who started late, 60% progressed. Those who started early, only 20% progressed. So again, showing the window of opportunity. So the conclusions essentially are TNF inhibitors can be disease modifying, especially if you start the drug early. How about interleukin-17? This is more recent in clinical use, so we don't have direct controlled trials yet. There was one study which was presented at the last conference, and it was a comparison of interleukin-17 versus an anti-inflammatory, but there were two different studies. They were trying to compare it to each other, so it is not a head-to-head trial, and that didn't show much of a difference. But at least the animal studies show that it is promising. This is an example from a rat which has the rat model of spondyloarthritis. You will see that there is significant new bone formation on the surface of the bone, and there is loss of bone within, so osteoporosis within. And if you treat these patients with antibodies against interleukin-17, you see that the new bone formation does not happen, and in fact the osteoporosis is much better. The density of the bone within is much better. So there is potential. We are waiting for results. Just to summarize, we talked about the new ACR guidelines. You should be able to see them in print soon. We talked about early diagnosis and the window of opportunity. We talked about disease modification, and also we talked about the new interleukin-17 inhibitors. And that's all I have for today. Thank you very much.
Hello. So my name's Laura. I'm the physiotherapist. I work at the spondylitis program here at the Toronto Western Hospital. Because I'm a physiotherapist, I'm very cognizant of the fact that we've all been sitting for the last hour and a half. So while I'm getting my presentation up, I'm just going to ask everybody to stand up at their seats, and then we'll sit back down when I've got it all set up. Now, let me see here. Okay. Is that working? Oh yeah, I need a mic, thank you. Okay, so we'll just wait for the presentation to come up. And I'm hooking myself up like Madonna. And you'll see what's coming later. Okay. All right, so everybody can sit back down. You have a little stretch. And I tend to move around a lot, so I hope everybody over there can see me. Okay, so first of all, I'd like to thank CSA, SPARCC, and our sponsors for inviting me to speak with you today. I'm going to be speaking to you about non-pharmacological management of ankylosing spondylitis. So you may ask, what is non-pharmacological management? So it includes various things such as self-management, complementary and alternative medicine, physiotherapy, diet, education. And it also includes exercise, for which we probably have the most evidence to support it as a form of non-pharmacological management for ankylosing spondylitis. So I'm going to be focusing the majority of my talk on exercise. And we know that exercise is a cornerstone for treatment alongside the medical management for AS, and this has been endorsed by our colleagues over in Europe. And as Dr. Haroon mentioned, also in the United States through recent ACR recommendations for both active as well as stable AS. And we know, based on the literature, that the benefits of exercise for AS are numerous. Exercise helps in pain reduction, it improves mobility and fatigue, it decreases disease activity and improves cardiovascular fitness. We know, and we'll learn more later, that it helps with depression, as well as it improves function and quality of life. But we have to keep in mind that not all exercise is equal, that different exercises target different body systems. So in 2010, the American College of Sports Medicine undertook a huge literature review of all the science looking at the benefits of exercise in the general population. And they came up with a position stand that reads, "The scientific evidence demonstrating the beneficial effects of exercise is indisputable. A program of regular exercise that includes cardiorespiratory resistance exercise, flexibility, and neuromotor exercise beyond activities of daily living is essential for most adults." And I highlighted beyond activities of daily living there because in order to gain the physiological benefits of exercise, exercise needs to be purposeful, it needs to be done at the right frequency, intensity, and duration. Now, I'm not negating the importance of physical activity, such as our day-to-day routines that we do, walking the dog. We might have a very active job, and we'll get into the benefits of physical activity later. But if we want to gain the physiological benefits, we have to work within certain guidelines. And these are the recommendations for the different forms of exercise. So cardiorespiratory exercise needs to be done about 3 to 5 times a week for a duration of about 30 minutes or so. Muscle strengthening, 2 to 3 times a week. Flexibility, 2 to 3 times a week. And I would argue, again, these are recommendations for the general population. I would say that for people who have ankylosing spondylitis, where stiffness is a major issue, that maybe stretching on a daily basis would be more appropriate. You also want to engage in something called neuromotor exercise. So you're probably asking, what does that mean? So basically what it means is training the muscles in a very functional, efficient, and safe manner. So I'm going to use quadriceps as an example. So if you go to the gym, you can go onto a machine and you can do leg extensions where you put a weight on the end of your foot and you do extensions, and that's a very good way of strengthening your quadriceps. But a more functional way of strengthening your quadriceps is by doing quarter squats. Okay, and I say quarter because you don't want to go too deep because then it puts too much compression through the knees. But quarter squats, just coming up and coming back down, is going to strengthen the quadriceps in a very functional way. Because when we walk, when we bend down to pick things up, when we go and sit down, that's a more functional way of training the quadriceps muscles. And that's what they mean by neuromotor exercise. So we know that exercise is really important based on the science, but our patients with ankylosing spondylitis actually engaging in regular exercise. So we looked at this question, it's now about 10 years ago, and I'll warn you that we are looking at repeating this study, so as Gerald mentioned earlier, surveys may be coming your way. No bias there. So what we wanted to find out is how much are people with AS engaging in exercise and what activities are they actually doing. So based on the results of this survey, we found that the majority of patients are engaging in either home stretching, walking, or attending their local gym, but they're not doing it to the right frequency in order to gain the physiological benefits. So we know as healthcare providers that we have a job to do to help tell patients that they need to be engaging in exercises, but also trying to encourage them in terms of ways of overcoming barriers to exercise. Because we all know that exercise is difficult. We all suffer from lack of motivation. We may be deconditioned. It requires investment and time, particularly if you have young families, you're in the prime of your job. And we also know that with exercise, there's delayed effect. So we don't actually see the benefits of exercise until about 6 to 12 weeks. So that's a lot of investment that we're putting into something, and we're not going to see the results right away. Also, there's sometimes fear of movement. Now, I would argue that with ankylosing spondylitis, generally people feel better moving around as opposed to resting, but certain people may be unsure in terms of whether or not they should be engaging in, say, high impact versus low impact exercise, and they might not understand the difference between hurt versus harm. So there are a number of ways of overcoming obstacles. And one is to clearly identify an exercise program and use meaningful activity in order to engage in exercise. So for example, we know from the literature that swimming is a good form of exercise for people with AS. But if you are not inclined to swim, or that's something that you're not really think that you're going to enjoy, then it's probably not the best activity for you to pick. We also know that there needs to be a balance between rest and activity. And we also need to assess our readiness for change. So I'm going to focus a little bit about this, and I'm going to talk about the trans-theoretical model. And I have a psychologist watching me, so I'm a little nervous about this. So the readiness for change model was developed to understand people's decision-making in incorporating behavior change into their day-to-day activity. And it was originally looked at in people who quit smoking. So psychologists wanted to understand what was it about people who could quit smoking independent of any exterior motivation. It was all internal. What were the things that led them to that particular change? And we can think about this readiness for change in trying to incorporate an exercise program, for example, into your day-to-day routine. So what they did is they looked at the different stages that people go through when they're thinking about or encountering change in terms of behavior change. And so the first stage is pre-contemplative stage. So I'm not going to exercise, I won't exercise. And then that over time starts to develop into, I might exercise, I'm thinking about it, to the preparation stage of I will. And I would argue that the majority of you, because you are here, you're either in the contemplative stage or preparation stage of change when it comes to how you're managing your spondylitis. The action stage is I am, so you are engaged in regular exercise. And the maintenance stage is that you continue to do so. I still am exercising. The problem is that life comes along. Sometimes there may be flares. Sometimes it's just something that has nothing to do with your disease. It's just something at work or something going on with the family, and relapse can occur. So you quit, you say, I'm overwhelmed, I've got other things I have to deal with that are more of a priority. And so sometimes we slip back in terms of our stages of change. The good thing is, though, is that you can re-enter these stages of change at any point, and you go through the same process. Another way of overcoming obstacles in terms of engaging in exercise is by applying SMART goals. So once you've identified an activity that is meaningful for you, it's important to apply realistic goal setting. So what this means is developing a goal that is specific, measurable, achievable, relevant, and timed. So I'm going to use an example here. Say you've decided that you want to increase your engagement in physical activity, and the way that you're going to do that is you're going to walk home from work, say 3 days a week, and you live about 6 subway stops from your home. You take the subway every day. So your goal is, specifically, you're going to be walking from home 3 days a week, and you think that you can achieve that goal within the next 2 weeks. It's measurable because you know it's 6 blocks or 6 subway stops, and you know that you're going to be doing this 3 days a week. It's achievable because you figure it'll take about 30 minutes to do this. And it's relevant because you need to increase your activity for your arthritis, but you also need to get home from work. And it's timed because you figure it'll take about 2 weeks. So by setting a very specific goal, it sort of breaks it down, and it's that, how do you eat an elephant? Well, one piece at a time. Has anyone heard that expression? The other thing that is important is ensuring that when you engage in a new activity, that you do it in a very graded manner. So you want to gradually build the intensity, duration, and frequency so that you don't relapse. So if you go at it too hard in the beginning, you don't want to fail. We want to build you up for success. So if we use the subway analogy again, rather than on the first go, you walk the full 6 blocks right off the bat, maybe the first day you get off 1 stop. The second day you walk 2 stops, and so on and so on. And I want to just mention a little bit about fitness devices. Is anybody wearing one now? Can you put your hands up? Oh, so there's a few, not bad. So these can be really good tools in terms of monitoring your activity, measuring your activity, goal setting. It can set reminders in terms of when you should be engaging in activity. You can connect with friends and family through social media. So I think that fitness devices do have a role, and they can be effective tools. So I'm going to just switch slightly here, and we're going to talk a little bit more pragmatically about exercise prescription. And this is not in any way an exhaustive list of exercise. It's supposed to provide a flavor, and it's supposed to provide you with the principles of exercise. And the main principles are that we want to focus on posture. We want to incorporate some form of stretching or flexibility. We want to ensure that we are strengthening our bodies, particularly our core. And we want to ensure that we are working in terms of cardiovascular fitness. And that's important because one of the studies that was published not too long ago, led by Dr. Haroon, showed us that people with ankylosing spondylitis are at higher risk of developing cardiovascular disease, so heart attack and stroke. And I'm also just going to touch on other forms of exercise. So first off, posture. So posture is the foundation of function, and it's the foundation of proper exercise. So this guy here is in proper posture. We call this axial extension. So what that means is when you stand up, you want to make sure that your ear is over your shoulder's over your hip's over your knee, and your knee is over your ankle. So that's considered good posture. The problem is that most of us in this room are on our phones, we're sitting, we're driving, we're watching TV, all these things where we're flexed. We sit for work on our computers. So this starts to feel normal, this head-forward kyphotic posture. And the muscles start to habituate into this head-forward posture so that when we ask our body to sit up tall, ears over shoulders, it feels like you're way back here, right? So one way that you can correct this on your own is just simply find a wall or a door, stand up with your heels back and your head back, kind of relax your shoulders, and then just walk away. So we don't want to be a robot. We're not talking about perfection. We're talking about optimizing your posture. So you want to do the best that you can with what you've got. So here's an example of not so good posture. Does everybody know who this is? It is Shaggy. Does anybody not know who this is? No? Okay, that's good. Okay, so Shaggy has pretty significant head forward posture. He's got rounded shoulders, and we're going to keep coming back to Shaggy. Okay, so as I mentioned, stretching is going to be important. And as I said earlier, I think that it needs to be done on a daily basis. When you engage in stretching, it's important to respect the pain. So I use sort of a numeric rating scale to kind of give the idea of how far you should take a stretch. So if 0 is no pain and 10 is the worst pain, you should take your stretch to about a 4. You want a little bit of discomfort, but it shouldn't be agony. It needs to be slow and prolonged, so you need to hold it for a good 20 seconds. And you don't want to bounce, because if you bounce, it may cause injury. It needs to be a sustained stretch. And don't forget to breathe. The breathing helps to improve the quality of stretch. Often people tend to hold their breath while they're stretching, but if you exhale with the stretch, you'll get a higher quality stretch. So here we've got Shaggy again. And so with Shaggy, we need to work on the front of his chest. So he's got tight pecs. We want to open up the chest, open up the abdominals. He's probably got tight hip flexors. We need to work on the back of his neck, hamstrings, and his calves. So again, I'm just going to show you examples of exercises, but by no means are these exhaustive. So this is a cat and camel stretch, and the reason I like this, the reason I like this is because it works the entire length of the spine from the neck all the way down to the low back. It works the shoulders as well as the hips. Another effective stretch is the hamstring stretch. So your hamstrings are located in the back of your thigh. There's different ways that you can do a hamstring stretch. Sometimes you see runners in the park, they put their foot up on the picnic table and they dive down to stretch their hamstrings, and that's one way of doing it, but it's not a very back-friendly way of doing it. By lying down, the back is supported, and if you used what I call arm extenders, such as a towel or a stiff belt or something like that, nothing stretchy, then you can actually improve the stretch so that it's really focused to the hamstrings. The reason I think the hamstring stretch is sort of one of the big bang for your buck stretches is because the hamstrings go from behind your knee and they insert into your pelvis. And if they're tight, they're going to rotate your pelvis backwards, and then you're going to compensate, again, by that shaggy head-forward kyphotic posture that we're trying to avoid in the first place. So by ensuring that your quadriceps are nice and loose, it keeps your pelvis in a neutral position and allows you to stand in better posture. Okay, strengthening. So in order to gain effects from exercise in terms of strengthening, it needs to be done about 3 times a week, and it's important, again, to ensure correct posture when you're doing the exercise. It's also important to ensure correct muscle activation. So, and this is where I think getting the advice from somebody who is knowledgeable about exercise prescription is helpful, at least maybe one-off or maybe with a follow-up, to make sure that you're doing the right technique for the particular exercise, whether it's stretching or strengthening. And I'm going to use lower abdominals as an example. Most of us have very weak lower abdominals and pretty strong upper abdominals. One way of strengthening these muscles is to lie down and do double leg lifts. But the problem with that is that you've also got very strong hip flexors. And chances are, if you're not doing that exercise correctly, your hip flexors are going to take over and you're not going to be strengthening your lower abdominals. So meaning that technique is very important when you start out with an exercise program. It's also important to progress from remedial to advanced. So it's important to make sure that you continue to challenge the muscles because they will become stronger, but you need to make them even stronger. It's not enough to just, be doing your one particular exercise and quit there. You need to keep ramping it up to the next level. And obviously, we want to make sure that the strengthening exercises that we're doing can be incorporated into daily function. So here we have Shaggy again, and we assume he's got weak abdominals. He's got weak back muscles, buttocks, and so what we want to do is we want to make sure that we train the core. We want to strengthen the core, meaning the abdominals and the back muscles working together synergistically, because that's the most functional way to train your back muscles. So in terms of a remedial example is the pelvic tilt. So this works the lower abdominals as well as the buttocks. A more advanced form of this exercise would be with a bridge. And so this further engages the core and it really engages your glutes, your buttock muscles. And the buttocks are important because in some cases, people with AS will start to develop hip problems. And the stronger your glutes are, or your buttock muscles, the less force goes through that joint. Here's an example of a remedial core exercise, which is bird dog. And this is more advanced, a plank. And I also want to just talk about the exercise ball. Does anybody have exercise balls at home? A few, a handful, not bad. How many use them? Okay, so I love the exercise ball because it's a simple tool that you can use to really engage the core. There's about 50,000 different exercises that you can use with the ball, and there's a lot of really good YouTube videos in terms of exercises you can use with the ball. Simply sitting on the ball is a form of core strengthening. The idea is that the ball is an unstable surface, so it requires your muscles to engage to prevent you from falling over. And there's different ways that you can challenge your balance while on the ball. When you sit on the ball, you want to make sure that your hips and knees are at a 90-degree angle, and that the average size for most people is about a 65-centimeter ball. You can get balls now at Canadian Tire, at Winners, wherever. About 10 years ago, you had to go to specialty therapy stores to do that, but that's not the case anymore, so there's no excuse. Okay, now I want to talk a little bit about physical activity. So physical activity refers to any movement that you engage in the day. So this includes recreation and leisure activities, Transportation, as we talked about earlier, so how you get to and from work. Are you stuck in traffic for an hour and a half each way, or are you walking or cycling to work? It has to do with how you move around in your occupation. Do you have a sedentary job or do you have a very active job? And this also includes household chores, games, as well as planned exercise. Oops, yeah. Now, again, in order to gain the physiological benefits of physical activity, which are numerous, we know that when you engage in regular physical activity, that it reduces your risk of developing chronic disease, it improves your longevity and independence, it improves your mental health. But in order to do that, you have to be working within a certain parameter. So 150 minutes of moderate intensity aerobic physical activity per week, or 30 minutes 5 days a week. Sounds a little bit more realistic. You also want to make sure, again, that you're engaging in a regular muscle strengthening program at least twice a week. And this notion of the importance of physical activity in people with inflammatory arthritis was recently endorsed by the EULAR group just this June. And they state that the general PA recommendations, or physical activity recommendations, include those 4 domains that we talked about earlier. So cardiorespiratory fitness, muscle strengthening, flexibility, and neuromotor performance for people with spondyloarthritis. So you may say, well, what is moderate aerobic intensity? So here's some examples of moderate and vigorous. So you got brisk walking, ballroom dancing, general gardening. It's all kind of obscure in some ways. I say use the talk test, something very simple. So if you're engaged in regular physical activity and you're sweating, but you're able to maintain a conversation, you're likely working within a moderate aerobic intensity. I just want to touch on swimming. So there's lots of evidence to support swimming in ankylosing spondylitis. They've done randomized control trials that have showed reduction in disease activity, improved spinal mobility, as well as cardiovascular fitness. One of the concerns with some people, particularly if you have neck involvement, is I'd love to go swimming, but I can't do the front crawl because it hurts my neck or I can't turn my neck. So this was solved by you guys. One of our patients told us that they go to the pool and they use a snorkel. And I've learned recently that they actually have training snorkels now, which are these full-face masks with a snorkel that goes up the top. And more people who just train or swimming as a form of training for them will be wearing these sort of training snorkels. So again, it's getting easier and easier to access this more specialized equipment such as balls and training snorkels than it may have been even just 5 years ago. Other forms of exercise such as yoga, Pilates, and Tai Chi are also very beneficial for ankylosing spondylitis. And they're good forms of exercise because they combine posture, flexibility, core strengthening, and some of them even combine incorporate a cardiovascular component, such as yoga. When you're doing the repeated asanas, like sun salutation over and over again, you do get a cardiovascular component to it. So as I mentioned, in some cases you may want to consult with somebody who has knowledge in terms of exercise prescription. That may be a physiotherapist. Physiotherapy in the province of Ontario is covered partially by OHIP, and I'll get into those parameters in a minute, but they're mostly out-of-pocket or through extended healthcare benefits. Publicly funded physiotherapy is offered to people over the age of 65 or 19 years or younger, or for those people who've had an overnight stay at a hospital. Also, if you're a recipient of Ontario Works or ODSP, then you would be eligible for publicly funded physiotherapy. If you go online, you can find those clinics that are publicly funded by typing in your postal code. And then I also want to mention the Arthritis Society's Rehabilitation and Education Program. And I see Ed sitting there, and I don't have the new logo up. Oops, I know, sorry. So the Arthritis Rehabilitation and Education Program, that is also funded through the Ministry of Health, and you would get your healthcare provider to refer to you, and then a therapist would come either to your home or meet you at a clinic close by and then provide you with an assessment and appropriate management strategies. Also, there's community-based programs available through your local municipalities, And then as we know, there's lots of online resources, including the CSA. And one that we sort of grew here at the Toronto Western Hospital is an e-learning module, and this is available through the public domain. So this has information on ankylosing spondylitis in terms of diagnosis and treatment, and it also talks about self-management strategies, and it has video instruction in terms of, you know, a basic exercise program that you could do at home. And I'm going to leave it there, but here comes part B. Okay. So, where's my phone? Here it is. So part B is we're going to get up and we're going to move. How's that sound? Don't get too excited. Okay, now, and I have to say this one thing. Where's Wendy? Oh, she's not here. So for those of you who that are watching this online, your screen is going to switch to a video that isn't us, but is already programmed. So your screen will go blank, and then it's going to switch off to something else, because this is online. So this is for all the online people out there. And then we will be back in 15 minutes, I guess, for the people online. Yeah. And for the people here, we're going to have some fun. Okay, so let me just see here. Got to put my glasses on. Okay. Oh, yeah. So this is Casey and the Sunshine Band. Who knows them? Come on. There's got to be more people than that. This is the Shotgun Shuffle. Okay. So in your chair, sit up. We're going to do chair dance, exactly. So you're going to bring your ear to your shoulder. And then up. Other side. Good. One more time. Good. Other way. Good. Now, we're going to go up and down. Up and down. And then we're going to pretend we're backing the car out of the driveway. We're going to turn and look over our shoulder. Don't run over the neighbor's cat. And then we're going to come back forward. And then again the other way. Hold. 2, 3, and back. Good. And then this again. Don't hit your neighbor. It's kind of tight in here, eh? Okay. And if you can, you're going to stand up. Sit down. Stand up. This is functional training of your quads. Sit down. And again, up. And then we're going to march. Good. And then we're going to punch. But don't punch the person in front of you. Good. Okay, and then we're going to, if you can, side step, clap, side step, clap. This is like disco. That's it. All right. Shotgun shuffle. Okay, and then back, knees up. Good. Good. Right, and then arm circles again. This is so good. Excellent. Okay, and then big breath in through your nose. And then out through your mouth. And then let's add the arms. Big breath in, out. And then one more time. All right. And Maria's got the doors open, and it's ready for a snack and break.
I told her she's a member, as of tonight, she's a member of the Spondylitis family. Good. Yes. We're going to pass them to one of us, coordinator. Okay, let's reassemble. Short. We are not exactly staying on time, but so it's a real pleasure to introduce our next speaker. Up until recently, this event has been dominated by Toronto, but we have a significant. It's like the Leafs. The Canadians are finally taking over the Leafs. Well, that's not much of a competition there, but. Anyway, it's a really delight to welcome Dr. Susan Bartlett from Montreal. Came in for the day. spoke to our rheumatology group today at a wonderful lecture. So Susan's a full professor of medicine at Nigil University. Primary appointments in clinical epidemiology and rheumatology and respirology. So she has a broad range of interests. Interestingly, she has kind of one foot in the U.S. She's also an adjunct professor at Johns Hopkins University in Baltimore, one of the most outstanding medical schools in the U.S. So Susan has a broad range of interests, increasingly spondylitis, but she's had a lot of interest in clinical outcomes in, say, rheumatoid arthritis and scleroderma. And the center theme, I would say, has been the patient well-being. How do we actually measure the well-being of a patient? And as you will see, it's partly the psycho-emotional aspects of disease, but also functional outcomes. So she's a really very skilled clinical researcher on that domain. So Susan, it's great having you here. Thank you for coming.
Thank you, Rob. It's my great pleasure to be here. I'm actually from London, Ontario, so I feel like an Ontario person, even though I'm living in Montreal and have been there for the last 10 years or so. And what I'm going to talk with you about is the emotional impact that comes with living with AS and other inflammatory diseases such as psoriatic arthritis. And I have learned much of what I know from patients, from being in the clinic, from listening to stories, from hearing over time what it is like to live with these diseases. And so I start with a quote from Mark Twain. So what do we hear from patients? What are the kinds of things they talk about? I'm going to show you a few slides from data from a survey that was done in the UK. I think it's very representative of what I've heard in Montreal, what I heard when I was working in Baltimore for 20 years. What are the concerns? Well, it's stiffness, it's pain, it's fatigue. Fatigue is a really big one. Fatigue is kind of the one that, the straw that breaks the camel's back. I can deal with pain and I can deal with stiffness. I've got strategies for that, is what I hear. But the fatigue that makes me not want to do anything, it makes me too tired to even come to an event like this after putting in a day of work. So common concerns. But these are concerns that are ever present. So when you look at how it's affecting people throughout the day, it's always in the back of their minds. It influences everything that they think about. Because living with AS, or living with psoriatic arthritis or rheumatoid arthritis, changes people and it changes their lives. Changes what happens at home, changes how you plan a vacation, where you'll go, what you'll do. So a tremendous impact on life, and it's no wonder really that we hear from patients that because of this ever-pervasive impact, because of the fact I can't really think about anything that I'm going to do without thinking how my disease may impact this. For instance, if I'm planning a vacation and I want to go away in February because we all know in Canada, really important to see if we can't get away and get some sunshine, right? And a little bit of warm temperatures. But many patients are very concerned, how am I going to feel? What if I have a flare? What if I pay all this money to go someplace and I'm not up to it? Do I do it? So it's a special kind of uncertainty that you're living with every day. And when you put this symptom profile together, the pain and the stiffness and the fatigue, and you combine that with how it affects everyday life, it is no wonder that people take a real big hit. And so when we look at the rates of depression and high levels of anxiety in people who have axial disease or ankylosing spondylitis or psoriatic arthritis or any of the inflammatory arthritis, we see that the rates of anxiety and the rates of depression are much higher than they are in the general population. And that's understandable, I think, because of the very many ways that everyone's life is affected. From the survey, I know that Gerald mentioned this a little bit earlier. You can see the poster out there as well. In terms of the comorbidities, mental health, number 2. And I say this to you, and I say this to the group in Toronto, and there's not a lot of surprise, but I'll tell you, when I say it to other rheumatologists, my rheumatology colleagues in Canada and in the United States, in fairness, in Europe as well. It is a surprise. And then they kind of scratch their heads and they say, well, but you know, it's a painful chronic condition. Who wouldn't be depressed? As if that should be or may be part of the condition, but it's not. And it shouldn't be. And it actually complicates things enormously. And the thing about depression and anxiety is we have effective treatments. And we can absolutely help you to feel a lot better. And that's really what I want to do this evening, is talk about how that works. But first, let me say a little bit about depression and RA. RA is so much of what I do every day. I'll lapse into it. Depression and AS and psoriatic arthritis. A recent systematic review came out. It included nearly 5,000 patients. So this is a lot of information that's combined together to give us a clearer picture, and it showed unequivocally that depression is very common. In fact, 15% of people meet the criteria for treatment for moderate to severe depression. Are 15% getting treatment? Absolutely not. I don't know what the figure is of who's being treated, but I know even in the general population, a lot of people go without treatment because they don't realize that treatments are available and that treatments work. And treatment, by the way, isn't taking a pill. I'll talk about that a little bit in a moment, but antidepressants have an important place. Many people are on antidepressants, and many people continue to be depressed on antidepressants, because antidepressants will only help a small number of people, and it's people with very severe symptoms. And yet 1 in 11 people are on antidepressants. You'd get as much benefit eating Smarties. Maybe a little bit more, because at least the Smarties have chocolate. So what is the impact of depression? Well, it changes you, it changes your body. People who are depressed absolutely have worse symptoms. It's not in their head. They're not imagining this. Their symptoms are worse. Their pain is worse. If they have psoriatic arthritis, their itching can be a lot worse. Their disease is often more severe. They have a larger number and more intensive side effects to the treatments that they're taking. So they absolutely feel worse. They have much more fatigue, because fatigue is very much part of the picture of depression. But it affects their social function and their physical function. So we see much higher rates of disability and withdrawal. You know, when you're not feeling good, when you're feeling down, you just feel like it's more effort than it's worth. And that's a cycle that becomes really problematic over time, because the more you withdraw, the less opportunity you have to be with people, and the less opportunity you have to have fun and enjoyable experiences. So think about what happened just a few minutes ago when we had Laura leading us in exercise. That was fun, right? It was a group experience. She made it really enjoyable. But most of us do much better when we're out around other people and we have shared experiences. And so when you don't feel up to going out and being with others, and you withdraw, you become more and more isolated. And psychologists like me really worry about that, because that is a scenario in which the depression can get worse and the anxiety can definitely get much worse. People who are clinically depressed also have less confidence in medication, in their providers. They're less hopeful about their ability to feel better. That's really, really important, because that's part of depression. In fact, we could give you medication. Cardiac medication is infamous for this. You give people certain kinds of cardiac medication and they become depressed. And their thinking changes. And they become much more pessimistic. But the problem is, if you have less confidence in your providers, you think they're good providers, but they're just not going to be able to help you for some reason. Or you feel like medications, there's great medications. We heard about them tonight. There has never been a better time to have these diseases, because we have never had as many medications that work as well as they do. But people are depressed because of that perception that they have, because of the mud-colored glasses that comes with depression. It just feels to them like the medications won't work as well. And in fact, there is some evidence that suggests that if you do have clinical depression, the treatments don't work as well. Because depression has an inflammatory component to it as well. On the other hand, there are some of these new treatments that actually help with depression too. So all the more reason why it's really important to talk with your rheumatologist about how you're feeling. They want to know how your body's feeling. They need to know about your back, but they also need to know how your soul is feeling. And if you're feeling discouraged, and if you're just feeling down, that's really important information. Because people who are depressed are less adherent to treatment. They're more sedentary. They tend to use more alcohol. And they tend to gain weight. And so all of these things, of course, are problematic. They make the conditions that we live with worse. So what I'm trying to do is build a case for you to convince you that your rheumatologist actually needs to know how you're feeling. Your rheumatologist isn't going to be the one to help you necessarily with those feelings, but they do need to know because that's part of who you are, and they need to treat all of you. And treating all of you can make a real difference. So how do you know if you're depressed? Well, I'll show you the tools that we use. These are available online. You can just Google them and you'll find them. And if you're scoring 10 or higher on this particular test of depression, the PHQ-8, that really means you do need to think about what's going on and talk with someone. So the kinds of things that people say are, I'm feeling tired all of the time. I can sleep for 10 hours and I'm still exhausted. I feel sad. I feel little joy. I am easily irritated. I just feel like being by myself. There are different aspects and different people experience depression differently, but these are the most common kinds of statements that people make. So I've highlighted, if you were more days than not in the last 2 weeks, would endorse these statements. That's an important sign to pay attention to. And similarly with anxiety, how do we know if your anxiety is higher than desirable? Because everybody gets anxious, everybody gets stressed from time to time. Who could not be stressed in 2018? But how do you know if your anxiety is at a level where it's getting in the way, it's no longer helping you, but it's actively interfering? Well, once again, if you're scoring 10 or higher on this, and you can see the kinds of items that people say, when I just can't get my brain to stop, I can't fall asleep at night. Interestingly enough, if you're waking up too early, if you wake up at 4 o'clock in the morning, that's a pretty important sign in terms of diagnosing depression. If you can't fall asleep, on the other hand, that's anxiety. So if you feel nervous and anxious and agitated, if you're irritable, if you just have this sense that something bad is going to happen but you're not sure, that's anxiety. We don't know a lot about anxiety because, frankly, we haven't spent much time studying it. But we do know, and I can tell you with 100% confidence, this is something we can fix. In fact, anxiety disorders are something that we can cure. Don't get to say that very often. But helping you with anxiety has everything to do with helping you look at the way you're talking to yourself. And we all talk to ourselves all of the time. In fact, I'm talking to you right now, and I'm probably speaking at a rate of about 225, 240 words a minute. But there's a conversation that's going on in the back of my head at about 350 words a minute. It's not just me, by the way, you're doing the same thing too. And it's, wonder what time it is. I'm kind of hungry. I wonder what I'll have for dinner. For me, it's, I wonder how many people are looking at their phones right now. So we always have this background conversation going on, and a lot of times we don't realize that the conversation we're having can actually make us feel much more agitated. And so it's really learning to understand what you're saying to yourself, and then talking to yourself the way you'd talk to a good friend, being supportive rather than critical. I like to say, stop shoulding all over yourself. I should be doing this, I should do this, I should make sure that I've got dinner on the table, I should make sure that the house... Sometimes it's toning that conversation down a lot. So when should you speak to somebody about how you're feeling, and who should you speak with? It doesn't need to be someone like me. It doesn't need to be a psychologist or a psychiatrist. In fact, you know, we're probably best able to help people who are really struggling and have been struggling for a while. On the other hand, there are many, many people who are very well qualified to help sort out if in fact you would benefit by seeing somebody like me. And the first person I would tell you to talk to is the nurse in your office, in your rheumatologist's office, if you're lucky enough to have a nurse. In Quebec, many of our offices don't have nurses, so we don't have that luxury. But nurses are great. They're trained for this, and they have a really good sense about it, and they're usually pretty easy to talk to. I'm not saying don't talk to your rheumatologist if you feel like you can, but if that feels a bit intimidating, physiotherapist, your pharmacist, really any member of the healthcare team that you feel comfortable about, just start the conversation. Start the conversation. It doesn't have to be long, it won't be involved or detailed, but at least you can get the ball rolling. Or you might feel more comfortable talking to someone in the clergy, a priest or a minister or an imam or whomever. It may be somebody at the local YMCA who's running stress management programs. Because you know what? All of the elements of stress management are exactly what we do for anxiety disorders. So there's help in many, many places. If you're working and you have EAP, a couple of sessions with your EAP counselor can also make a real difference. But we also have some great resources that are now available online, many of them that were developed right here in Canada. And part of the reason I'm here tonight is because the CSA has asked me to work with them to try and bolster and to bring more resources and put them online and make them available. Because there's so much that you can do yourself just by being more aware. And it starts with understanding, first and foremost, that yes, this is part of your life, but this does not define your life. And it needs to not define your life. You need to get your life back, and you need to figure out how you're going to get on the rest of your life. Taking into account, you can't ever get rid of this, and you can't push it entirely out of the way. That can be a problem too. But how do you find a place for it? You need to learn how to manage things like flares, because flares can be one of the biggest problems. You're doing everything that you're supposed to be doing, and then all of a sudden, out of the blue, you're exhausted. You feel terrible. What did I do to deserve this? You didn't do anything. It's just part of the disease. The unpredictability is really, really hard to live with, because it usually happens that when you have something really important, or when we're going into the holidays, that's when these flares sneak up behind you, right? So learning to self-manage your disease effectively means being a lot like a firefighter. A firefighter spends a lot of time doing the preventive work, making sure they're doing a lot of things every single day to feel good and to help them feel the best that they can be. But a firefighter also has very specific skills so that when a fire erupts, they know exactly what to do. You need both kinds of skills to do this. You need to figure out how you're going to claim your life back and live your best life. And that does mean coming to terms with AS. It does mean finding a new normal, a different normal, and it often means allowing yourself to grieve and to accept that things are going to be different, but different doesn't have to be bad. That's why I started out with the quote from Mark Twain. Yes, you'll learn things that you would learn in no other ways. But many people, as they come through and live with these diseases and become more comfortable, find that there's deeper, more meaningful relationships with family members, find that they learn things about themselves that is reassuring and that is comforting, and find a purpose in moving forward. You're going to have to learn to be more flexible. There's no two ways about it. You can't do things the way you used to do them. Get used to it. It's a little bit, I think, like becoming a mom. Like, I could never do anything at 100% once I started having a family. Everything at best gets 80%, and that wasn't easy to come to terms with, but I did, kind of, over time. Be flexible. Be flexible when it comes to what you're expecting of yourself from work and from family and from friends. You'll need to create a network a network that can give you both support and emotional care. And all of this is going to be dependent on learning to be a better communicator. And on this, there's no alternative. You're going to have to educate your family and your friends and your coworkers and teach them how to interact best with you. You're going to have to be honest with your healthcare team about how you're actually feeling. Because unless you do these things, the people around you who love you and care for you and want to support you have absolutely no idea how to do it. You know, what you see all of the time is that the person who has the disease feels like a burden and feels guilty. And so they keep a lot inside. They don't want to share it. They're not comfortable with how they feel. They're not comfortable with saying, I don't want to do this. I'm too tired tonight. They're worried that the family members or the friends or the co-workers won't understand. And a lot of times they say to themselves, well, I should be able to move forward. I should be able to do this. I'm letting myself off the hook. That's not right. On the other hand, the other people in your life are saying a lot of things to themselves, too, when they see you begin to withdraw. They're wondering, what did I do? Like, what did I say? Did I say something wrong? Did I make them angry? Am I bothering them? So you act differently. They act differently. This is the perfect scenario for misunderstandings. And the only way through this is to talk about it. And it's not easy. It's not easy, but it gets easier with time. It's a lot like playing tennis. You know, like the first few times you go out on the court and you try and hit that ball and it just doesn't work. But the more you practice, the easier it gets. And it's more honest and it's more authentic and it's much more rewarding when you can let yourself come through and when your family and your friends and whomever you choose to share this with really can understand how it is you're feeling, what you're going through, and why sometimes you do just need to shut down, go away, go in the room, go under the duvet, bring your bar of chocolate with you. Well, maybe that's my fantasy. I want to reinforce what Laura was saying about moving. Moving is the best medicine. You know, exercise is important. It's really important for everybody. For you, it's absolutely essential because exercise is one of the best antidepressants that we have. For people with mild to moderate depression, exercise is as effective as medication. It's as effective as therapy. It's free, and the side effects of exercise are great. In fact, the Canadian Family Physicians Association has taken the position since 2011 that for everyone with mild to moderate depression, first line of treatment needs to be exercise. But you know where exercise is really magic? With anxiety. There is nothing that helps your body calm down and relax like exercise. So, did you feel better? I felt better just after our little exercise interlude that we had a few minutes ago. You get more energy when you exercise. You sleep better. These effects are within a few days of exercising. You don't have to do this for 6 months to feel better. In our randomized controlled trials, people tell us within a week they're sleeping much better. You feel more confident. You just feel better. Your self-esteem goes up. And when people begin to exercise, they often begin to do a whole lot of other things, like they eat healthier. They feel like doing that. They stop smoking. And stopping smoking is really important, because one of the things we understand is that if you smoke and you use even the very best medications that are out there, your medications are not going to work nearly as well. Exercise helps you manage your weight. And we know that weight is also a major barrier to having treatments work as well as they could. So what's not to love about exercise? The side effects are phenomenal. If you'd like some more information, here are some resources that I routinely refer my patients to that I have a lot of confidence in. The CSA has some materials, and as I say, we're working on new materials and more materials for you. There's great materials online in the UK. The UK has been 20 years ahead of us in terms of developing materials for patients to help them self-manage. There's the Arthritis Society. The Arthritis Society has done amazing things in the last year or so. There's been this massive revamp of the website, and you're going to find a lot of great stuff and a lot of good stuff, really good stuff that I'm very comfortable with because they had me go through it in detail around mental health. The U.S. Arthritis Foundation has good things as well. If you're concerned about your mood, then I absolutely suggest you go online to the British Columbia Antidepressant Skills Workbook. This is one of the best resources out there, and people from all over the world are using it. It's available in something like 13 languages, and it's a workbook that you go through, and it helps you learn to understand what you're saying to yourself. It helps you assess your level of depression. It helps you set goals around exercise. It helps you get moving and move in a more positive direction, and it lets you know when maybe it might be time to talk to somebody more. So I will stop there, and we will have a chance to have some questions in that in a few minutes if you have more questions.
Thank you, Susan. That was really wonderful. Thank you very much. So our last speaker, before we open to questions, is Dr. John Flannery. John Flannery is the medical director of the musculoskeletal program at the Toronto Rehab Institute on University Avenue, part of the University Health Network. He's also the head of the comprehensive pain program there and recently developed a novel research program, the Toronto Research Pain Institute. So he's a really important part of the management strategy of AS because as rheumatologists, we're pretty good at treating inflammatory disease and inflammation. But there are many occasions when pain is the central challenge and the central domain to be conquered. And we really value John contributing to this discussion. So welcome, John. Thank you.
Is our IT person able to come and help set up? Oh, he's coming. Here we are. So, before he gets this set up, just a show of hands of who knows what a specialist in physical medicine or rehabilitation is. Or podiatry is the American slang term that they came up with. So if that had been maybe a decade ago, not too many people would have put their hand up. But interestingly, it's one of the oldest specialties in Canada. Started after World War II, which after the last couple of days, there's been an awful lot of talk about World War I and II. After we could keep people alive from those devastating injuries, we realized that you need a team. And so a lot of what has been said so far tonight is actually my talk. So Gerald, Bob, Nigil, Laura, Susan, thank you. I'm done. It was great to hear all those things because actually I'm going to reiterate an awful lot of what they've said in this talk. This is really what's new in the treatment of chronic pain. Not too much, except maybe cannabis. Right? Cannabis is now legislated, and that's a big area of interest. I'm not going to spend too much time other than sort of say we need a lot more research in cannabis. It's really a bit of where opioids were about 40 years ago, and so we need to be very cautious in how we move forward in that. So, disclosures. I have none. I am the operations lead also for the ECHO project, which I'm going to speak a little bit about. I did have some nice handouts and pens to sort of give to you guys, but the taxi took a wrong turn and got me so frustrated on my way over here that I left them in the cab, and they're gone somewhere around the city. But if you do need some information, there's certainly our website is very well tooled with some of the information. So, outline, I'm going to talk about chronic non-cancer pain, the background, some of the treatments, medications, therapy, the interprofessional care, some interventions, then the education piece, because I think it's a really important aspect, because one of the most important aspects, to be honest with you, for what's new, is around education. We need to get the information out and translate it into the family physicians and the practitioners to help individuals with chronic pain. It's a lot bigger than the little program that I have or the network that we've created across Toronto called TAPME, Toronto Academic Pain Medicine Institute, which looks at multiple different academic centers, or the Adult Pain Network that I sit on for the province that looks at all the academic centers. So education is really one of the key areas. So here's the, I give the last one of our cycle of 21 for our ECHO project, which are little mini didactics that we do on this educational forum that I talk about. And this is that sense of awe. So wonderful, just wonderful. So much for holding the whole group in a sense of awe. So here, this is me falling down. I'm human, I fall down all the time. It's a real important aspect to understand that a lot of these things can be done by many of the team members. I just happen to be representing one of them as the medical director and a physician that works in that team. But every single member, like our physiotherapist, our occupational therapist, our social worker, and so on down the list, is critical to the management. And what does work in chronic pain? Interprofessional teams. The difficulty is try to get that message out. That's where ECHO comes in, because it can actually get it out into family health teams. And the ECHO now actually has a rheumatology one that Claire Bombardier and Amanda Steinman, who are a couple of rheumatologists who work with us, have actually got an ECHO to try to educate family physicians in underserviced areas, which can be Toronto, because if you have to wait 6 months to get to see a rheumatologist, that's far too long. Or it can be rural areas where there really just aren't any of the specialists. So this is now to get you to understand chronic disease. So back pain, right up there. And I better put on my glasses here. Arthritis and rheumatism, also up there. So you guys have a couple of areas that cover the biggest part of chronic conditions. Ed Wagner, in a landmark sort of paper back in 2000, talked about a couple of important things of how to manage chronic disease. So the people and the process is sort of the summary of what you take out of this. So the interprofessional team, as I mentioned, is critical, and it can be broader than just those other areas, but we have a chiropractor who works in our areas. We have PSWs, we've got OTAs and PTAs who can also deliver an awful lot of information. Interspecialty care, so that's some of the stuff where Bob or Nigil and I, or the psychiatrists that I work with, we get together and manage this as best we can, because it's really important. As you've seen all these little Venn diagrams of this overlap between psychiatry and pain, and mood and pain, and anxiety and pain, it's huge. So I can't do this without really good understanding of what my psychiatric or psychological colleagues are working on. And the same goes with our social worker, who provides an awful lot of support for that. So interspecialty is another key component. I've worked with plastic surgeons on burns, because burn has an awful lot of pain. And it's really helpful to have the two. I've worked with Raj Ramprasad on spine, and the two of us collaborated. I actually came and worked with him for a year in a clinic once a week, where he helped me understand spine better, and I helped him understand rehab. The same happens with the geriatrician. As we age, we get older. Arthritis becomes more. These conditions become more prevalent and more problematic, and dementia starts to come into these equations. And mood, as we get more isolated and we lose our loved ones. So there's these overlapping Venn diagrams which are important. And the process, you need population management. It's not just one drug, it's not just one intervention of therapy, it's all of these things. You need protocols on how to do it. Self-management is critical, and intense follow-up, because people get started, but then we've got to follow them and help them, usher them along. So this is a quote from one of the neurosurgeons that I met back in my first year of medical school, John Marshall, a lovely Scottish guy, and he said, pain, it's the friend that warns you and the enemy that destroys you. And when it gets dysfunctional, it becomes chronic. The context of chronic pain, it's confusing and complex. It's kind of like hitting a moving target. Things change, patients change, they age. So it's constantly adapting, which is the reason for the follow-up, which is critical. The research is changing, and constantly we're seeing different things that we thought weren't all that helpful, now are helpful. When I started medical school, nutrition was just something that was off on the side. Now it's become critically important, because we know that the things we put in ourselves can actually affect how we feel. There's many opinions too, and you need to be cautious around this. Physicians can generate an awful lot of money when they do procedures, and people who are desperate may want some of those procedures. So it has to be tied to the goals that Laura talked about. It really has to be tied to goals, because getting your pain down isn't the answer. It's making you functional. So we have to really focus on that. And people often use this visual analog scale. How's your pain today? Well, it's an 11 out of 12, or 11 or 12 out of 10. And that's what people feel. So that tool is no longer all that useful. So you have to keep that in mind when we're looking at it. This is how physicians feel. Chronic disease patients, they take up, they're 20% of my population, but they take up 80% of my time. So we have to be aware of that fact, and so that's where the education comes in. It affects about 20–25% of the population. Seniors, as they age, become even more so. It's a very costly event, particularly in all Western economies, because in the States, for instance, it's billions, hundreds of billions of dollars. This is frightening. Training. So vets get 87 hours. And med students, maybe 16s, GPs in their training about 3.5. Scary. Absolutely scary. So guess what comes from that? An opioid crisis. Because it's like giving a handgun to a 4-year-old without showing them where the safety is. Right? So here's some medications. A lot of this stuff. So here's some, there's 5 pieces of information here. 15 to 30% of the population are in chronic pain and are using opioids. We're number 2 in the world. Canada ranks 2nd, only the US, per capita of consumption of prescription opioids. Scary. Family physicians, dentists account for about 55% of how this gets started. First Nations, as we know, a very vulnerable group. Very, very vulnerable, and it's complicated. And opioid deaths, well, it's just rising. Again, this is the opioids and how much it gets prescribed. 9 million prescriptions were filled in 2015-16. 9 million. There's only 14 million in Ontario. So that's scary. And SARS, here's the deaths associated with this. Who remembers SARS? Right? My first day of practice at Hillcrest, or Toronto Rehab Hillcrest site, I was slated to have my first clinic, and it got canceled because of SARS. So I remember it very well. That was, really shocked Toronto, shocked the world. 44 deaths, and here we are with 638. People remember it. This is that quiet little killer that's been growing year after year and now become quite involved. Here are some of the actions that we're taking with this. So prevention, treatment, harm reduction, and enforcement. So on the prevention side, that's where Bob was talking about getting that early recognition for individuals with ankylosing spondylitis helps. You can get them into, remission if we get them early. So we want to get that diagnosis. So we have to get out the skills of management. So that's what Claire Bombardier and Amanda Steinman are trying to educate physicians and nurse practitioners in these rural, underserviced areas about the recognition part, so it doesn't take so long. Treatment, we've talked about that, gets you into remission, but there is no cure. We know that, so we have to then manage it. And we've already heard that chronic pain is one of the highest, as is mood, and sleep and other fatigue and aspects are right behind it. So no prevention, no cure. Treatment is improving. It's amazing, some of those new biologics. They come with a risk, though. The goal is to get the disease diagnosed quickly, for months or up to 6 to 8 years, which is what the average might be for people to get diagnosed, and that's a long time. Make sure you've got the definitive diagnosis, because it can get complicated. These areas sort of overlap sometimes, and then we're uncertain as to which one to go on, so they try to make sure, and then manage chronic pain if it exists or develops. So these next 5 slides are sort of the comprehensive approach. So this is from Andrew Smith, who's one of the individuals who works on our pain program. He's a neurologist who did some extra training and works at CAMH in addiction medicine. And so I borrowed these next five slides because he uses them as part of our little mini didactics for the ecosystem that we utilize. So assess, define the problem, diagnose it, other issues, the mood, the anxiety, the sleep, the addictions. Those are all things that Susan talked about. And then personal management and self-management, because I can't make the patients change. I can encourage them to change, but they have to do the work. I don't get them to take the medications. I encourage them to take the medications. So it's really up to the individual. And that's hard because now I have to try to motivate them around some of those aspects. So pillar 1, comprehensive assessment. Horses are common, zebras aren't. The patients who come to our clinic have usually been seen by multiple individuals. I see in our group sees about 900 new consults a year, and we follow about 3,000 patients in our clinics. They've usually been seen by multiple specialists by the time they get to us. So if we can get to them a little bit sooner, it's helpful. They've actually, our average time in pain, unfortunately, is about 6 to 8 years that they've been in pain before they get to our clinic. So it makes it hard for us to make some changes, but we still have some of those benefits. So understanding the general history of low back pain and using the core back tool, which I think Laura talked about, getting those core muscles involved, making sure that we do a neurological history to make sure we haven't missed anything. A lot of masquerading aspects can go on, or other diagnoses that are present at that time. And then a pain history, identifying that the individual is the greatest risk of aberrant behaviors, because if there are opioids to be used in this, because they are also a great drug, I use them a lot because I get people functional. And once I get to the function, it's very easy to wean people down off the opioids. It's very, very easy. But we got to get them there. So pain is that barrier. We've got to get them over that barrier. Opioids are a very, very good medication. We just have to use them with the goal-focused behavior that Laura was talking about. We have to know what we're trying to do. And then, make sure we don't stigmatize them, because then people are very sensitive around the emotional aspects. So we have to develop skills in how to manage that. So the core tool is an effective tool just for people to use, and Laura's actually got us to do a bunch of those exercises right now that were geared towards some of that management or demonstrated some slides. Pillar number 2, define the underlying problem. So we've talked extensively about that. We need sometimes to do investigations, but we need to be cautious about doing that because it takes time. And now we've delayed getting started on something because we've planted a seed of doubt that we need to. So once we've got the diagnoses confirmed, we need to move forward in this and then identify and educate people around what that looks like. Not everybody understands what inflammation means on an X-ray or an MRI, and it's very helpful. One of the aspects that I learned is how Raj Ramprasad explains to every single one of his spine patients just what's going on in that spine, and it's such an effective tool. If a picture's worth 1,000 words, you can imagine on MRIs there's so much rich information, and it's sitting right in front of us. We just need to connect the patient, because now they know what's going on. The chance of them being motivated to go and do something about it is much higher. So education, again, is one of the key areas. Define it, nociceptive versus neuropathic. There's different treatment options that we can look at that. And then those other symptoms and conditions, the depression, the sleep, the anxiety, fatigue, sexual dysfunction, and addiction. I'm almost stealing this from my colleagues' slides. The personal responsibility and self-management. So interprofessional care, the refractory patient, and external locus of control are sort of 3 domains we talk about. So clinicians need to practice it. It's easy to say interprofessional care, but it actually means you talk to your colleagues and you find out what's going on with each one to sort of make sure. So I send emails to my colleagues to make sure I got things understood. And I speak to them about that. So Bob and I have talked many times, and Nigil and I have talked many times to find out what's going on around certain patients. Now, it might be in an email traffic, but at least it's communication, because that's one of the things that we can leverage our technology. When you have someone that it doesn't work, there's a lack of buy-in in the self-management. So people often get to me without this stuff. So the first and best chance for good function is early on, before they've developed some of that recalcitrant nature that we cannot seem to move things forward. Provocative management versus proactive versus reactive. So it hurts Well, if it hurts, your anti-inflammatory may be helpful. If it hurts, an opioid medication may help you to participate more effectively so that you can get that range of motion, maintain that function, get that posture established so that you're not fighting that each and every day. Those setbacks, flare-ups are critical. So now we have to develop some resilience underneath this to sort of say, yes, it's anticipated. So we don't lie to patients saying it's one and done. You know, back pain, you'll just have this one episode. It's going to come back. I guarantee you, your sore muscles are going to come back. But how you manage it is one of the important things. So don't stop. Keep moving, as we've already heard. And that external locus of control is a concept where we need to educate patients and families about the management techniques. It always seems to be something happening to them. We need to help them understand that they can control that and try to give them back that external locus of control internally. Opening your own internal medicine cabinet is one of the expressions that we use. So again, these are the types of goals we talk about. So I was pleased to hear Laura do all the SMART goals. And I have one of my colleagues, Mandy McGlynn, that she knows very well. She and I lecture on SMART goals, and we have a whole bunch of different ways to help people with it. But really, the underlying message, trust, rapport, and collaboration with your patient. Because if they don't trust, they're not going to do it. So I got to build that trust, and I make that explicit for my fellows and my residents and my medical students that are working with me, that that's what this is all about. Eye contact, understanding, listening to the individuals, because if you don't do that, the individual's not going to want to go do the exercise. They don't get it. So the motivational steps, it's another important thing. So engaging is critically important. You have to build that foundation, and that's the part towards trust. Focusing and clarifying the direction of what's on the horizon. So it's going to be a long journey. It's not going to be quick, but we'll be there. We'll continue to see you at intervals of follow-up, 2 months, 3 months, and keep moving, making some changes, because there's lots of things that we can do that we'll talk about, and then making sure that we get them towards the planning aspect. And how do we do that engagement? Or is this way of sort of navigating these murky waters? So open-ended questions. Affirmation. It's really important. People have to be heard about this and understood. Reflection. How is that getting you to move forward? I know it's difficult. Those mood issues are really problematic, but we need to engage in some of that activity for you to help move forward, to help make this pain better. Because the 5 things that work, for regardless of whether it's an inflammatory chronic pain condition or a neuropathic pain condition we've already talked about, but I'll just go over them. If you smoke, stop smoking. It's so prevalent, it makes pain worse. And it's not just like a little, it's massive how much. So I'll get off my soapbox. 2, if you don't sleep, we've got to try to make sure you sleep, because the sleep and the fatigue are very problematic. So that's usually another big area of focus, and not all of these are with medications. There's our other strategies, but sleep is critical. If you have limited range of motion, which we've already heard from Laura, get better range of motion, so that's the stretching. If you have weakness, which usually happens with the deconditioning, get better strength. And then cardiovascular fitness. So those 5 things are critical under all of this, and so that's where we start to look at how we can manage them more effectively. Crucial conversations. Anybody heard about crucial conversations? Put up your hand. So I'm certified in this. It's an area of interest, because how do you get people into that conversation quickly and effectively? So this is my little, pop culture kind of stuff. Start with the heart, right? Why? Because if you get your heart right, you know what's right for the patient, it makes it so much better, because then you're going to have your essence, your being, your presence is going to be there. So you have to make sure that their goals align with your goals, which are usually around trying to make them more functional. Watch and listen. Patients may not tell you everything that's going on. So you really have to just use your ears and watch your eyes. And physicians have forgotten a lot of this, right? Because they're telling you something. There's a message. And when you reflect back some of that stuff, they go, oh, he's actually listening to me. What the heck's going on? Most of my physicians don't. And so we really need to impart that. Control your emotions, because these patients have usually had a long time of pain and they want to get some of this off their chest. And we have to help them to understand that their emotions are going to play a big role, as Susan's already said. Your anxiety makes your pain worse. Your depression makes your pain worse. And these two feed off of one another. So we have to help that to understand it's physiologic. So the breathing technique, square breathing, is a very good technique at calming people down. So you just get them to breathe in, as we did with our arms, and then breathe out. And sometimes people get the hold. So there are techniques that actually work with the physiology. State your path. So this is what I think is going on. And as good as you can state your path, you then have to listen to theirs. Because that's another piece that's important in this. And then once you get it, you get smart and you get an action plan. So we've talked awful now about chronic pain. Now I'm just going to go into the treatment, the meds, the therapies, and the interventions very briefly. So management strategies, education, 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 and more education. Communication of diagnosis, so we have to be firm and commit to individuals so they actually know what they have. And there might be just an inflammatory point, or there might be this depression or this anxiety. And we have to talk about it because it's going to impact. If we deny it, it's not that we're saying the anxiety caused your pain or the depression caused your pain, it's amplifying your pain. And so that's an important aspect. Goal-focused behavior, and so the SMART goals, we always say it's all about you. It's about your goals. And these things don't cost? Well, they actually do cost. It costs patients and family their time, and it costs the treating clinicians their time. So we have to understand that what we're trying to do and make it explicit, not just implied, but explicit. So we often give education, actually get patients to sign the form, because everybody grabs the information and it goes in the bucket and in the garbage. But it's important. There's some really good educational tools. Our technology is fantastic. 23 and a half hours. Has anybody seen that video? Put up your hand. By Michael Evans. It's a fantastic video. You should just go Google it. I hate the guy. So he's down in Google right now. He used to work here in Toronto. He's a family doctor. You might have seen him on CTV. He was usually, or CBC. He was one of the physicians who was usually on, being interviewed by Peter Mansbridge. I hate him because he took all of my training and distilled it down initially into 9 minutes, and then down into 8, and now it's in about 6 minutes. And it talks about that 30 minutes of exercise that Laura was talking about. So there's some great educational videos that we need to take advantage of. So the drugs, opioid trials, after a good goal, focus on the trial to see if it works or if it doesn't work. So now we can decide, these aren't working for you. The non-opioid aspects are another sense, and there's a whole list of them. Tricyclic antidepressant, anti-seizure medications, SSRIs and SNRIs, they work because they talk in the pain center, which is right next to the mood center, and so those two interact. So they can be effective. And we're not saying that you're not able to cope and manage with these things, but we're just saying that that might help your pain become a little bit less so you can do more function. Topicals are another thing that can be quite helpful. We've got better compounding agents that actually penetrate into the nerves and go upstream inside the nerves. And cannabinoids, well, that's an interesting area. Like I said, we have very little information. We actually tried to do a randomized controlled trial that we're putting together as a group. There's so little information out there that we actually have to just do an observational trial. So our application to CIHR, big granting firm in Canada, is an observational trial because there's only about 8 good randomized controlled trials out there that have really only assessed about 200 patients. And this is now free to go, or available for everybody across Canada now. So we need to be careful because everybody's coming in and asking about this. And it has its place, no doubt about it, but we need to be careful. Interventions, again, it helps if there's some goal focus because, again, the nerves are smart. After we burn them or block them, the pain comes back. So it's a temporary relief. It might be 6 months, but it's only temporary. So again, we need to be able to sort of understand that it's around a goal. And then manage the comorbidities that we've already talked about. So here's the WHO ladder. This is where we progress up to management of different strategies. So we've got some science around this. Here's for the neuropathic pain that I talked about previously. These are some other medications where cannabinoids are on there. This is how we look at a multimodal approach. So we overlap these different things because one medication at a high dose might be really good, but a couple of medications at lower dose to decrease the chance of side effects might be equally as good. And so that's why we sometimes get people on a cocktail of different medications to try to manage the different sources of their pain. We've talked about this. It's really important, and this is just one slide that I've devoted, but look at all these different things. Exercise, psychological and education, manual therapies, physical modalities, and others. The others are really quite important. Ergonomic aids, braces, some meditation or acupuncture. These are all very good methods to manage it. And so it's really about taking advantage of all of these different things, but this takes time. The interventions, they help, absolutely, but they're not, the be-all and end-all. It's really around how to have that helpful towards these goals. So we usually talk about the 3 M's or the 3 P's. So the 3 M's, movement, mind, and medicines, or the 3 P's, the physical, the psychological, and the pharmacological. It's an overlap of all 3, and it's having a plan. So what is self-management? The individual's ability to manage the symptoms, treatment, physical and social consequences, lifestyle changes inherent in living with a chronic disease. So again, that's that internal medicine cabinet. Collaborations with family and patients are critical, so that's the family, our interprofessional approach. And now I'm just going to briefly touch on the ECHO project. Has anybody heard of ECHO here? A couple of people. It stands for Extension of Community Healthcare Outcomes. It has 4 pillars or 4 key aspects. It leverages technology. So using these little phones that we have, we can talk to people all over the place in a structured format so that they can get education and do case-based learning. So case-based learning, they present the individuals who are participating, nurse practitioners, pharmacists, family physicians, they present the cases. It's the cases that keep them up at night that they're presenting, and we facilitate peer-to-peer learning, and then if necessary, a little bit of education from the hub. It's a hub-and-spoke model. Best practices, so we keep asking people to follow the best practices, and then we monitor the outcomes. And we've actually started to show already with our chronic pain, which was the first in Canada, that we've actually been able to show that family physicians' prescription of opioids come down with this. And we've monitored family doctors in the community, and their prescription rates really haven't changed. So the effect is there from our education. So the result, better care for more people. So that's really nice to be able to see it. So that's on the individual, but now we're teaching a family physician essentially how to fish so that they can get their own fish, and they don't have to rely on putting people into long waiting lists to see specialists. It started in New Mexico. Sanjeev Arora, he's a hepatologist, and people were literally dying to get to see him. So he lived in Albuquerque. And none of the patients, New Mexico was number 49 out of 50 states for its outcomes with hepatitis. So he tried to change this, and he did change this. And he published a landmark study that got published in the New England Medical Journal around how primary care physicians who are taught and trained are just as effective as the specialists. So cure rates by both the spokes and the hub were equal. Except in another interesting, rehab closer to home, adverse reactions in rural areas were less than going to the specialty clinic in Albuquerque. This is the spread. ECHO is catching on. The goal is to have 1 billion by 2025, so touch 1 billion people by 2025. It's in 31 countries so far. We got another 139 to get to. There are 11 super hubs. We're one of the super hubs here, so we train people rather than go down to Albuquerque. They can get trained here in Toronto now. We have 18 ECHOs present in Canada, or in Ontario, I should say, and there's another 10 sites all in the rest of Canada, so it's growing. High rates of opioid prescription and overdose and deaths. This is one of the reasons that we went at it. And here's our hub model. So this is us. And then the screen, you can see all the sites around that people can participate. So we have people from all over the province participating. We have modules, a curriculum that we follow. So there's 21 of them. And we focus on things like chronic pain fundamentals, opioid and addictions, special topics like diets and so on, special populations like individuals who are pregnant or pediatrics. We look at participants selected. The participants get to select things like myofascial pain or trigger points. So that's a method. This is where we've reached across Ontario, so it's working. This is who gets in. Physicians, the largest group, nurse practitioners. So we've really got some education happening to people who can make a difference. We also have some boot camps, so not everything can be taught over the web. So sometimes we need to have people get together, and it helps because now we form that team, and these people feel more empowered to become local champions of chronic pain in their rural area. And they teach us. They're so creative in these areas. They teach us each and every week, which is fun because then I'm constantly learning. So we facilitate this each week. So this is putting it all together, right? Update on pain. Education, education, education. It's really important. What ECHO does, it gives a knowledge translation. It builds capacity so that we can have more people who know how to manage it. It leverages technology. We've got great technology, and it's unbelievable. We have a librarian who participates. She posts things right afterwards, questions that they ask. They can get some answers right then and there. It takes 2 hours of their day, so they have lunch, and we have lunch, and then they go out and they see patients at 3 o'clock. It's finished at 2:30. By 3 o'clock, they're seeing patients. They implement the change right away. So this is a fantastic model for chronic disease management. It's in our rheumatology. It's in mental health. We've got elderly individuals that are also working at it because we have an aging population. Communication of the diagnosis is critical. You get commitment. You get our goals to focus on behavioral change. The therapy, we've already talked about, the medications, the interventions all have a role to sort of play, and we really have to manage those comorbidities. So the principles: get a really good team. Create an interprofessional team with the culture that's there. Get trust for the whole team and for everybody, and build that trust with the patients, and never forget that humans are humans. We have to understand that that's part of it. You need to master your patients with our patients, so we have to make sure that we focus on the people who are here, and then start with, the process is just goal-focused. Make sure that it's understand it's not an instant, quick fix. We are going to see you, and this is going to be over time. Keep patients accountable, and the patients then keep us accountable. And then when you have some of the patients that run into problems, you might need to spend a little bit more time. Thank you.
We have our expert panel assembled in front, and Wendy has been taking your questions. We'll start with these. If there's something that has occurred to you during these talks that you didn't write down, we got microphones right there. So we'll start with this. Wendy's going to quarterback the Q&A. But again, if there's something on your mind, feel free to go to the microphone.
You have more? Wow. Oh boy. Okay.
You can't submit your own question.
Wow.
Should I go through some of the last ones?
Do you mind doing that? Okay, there we go. Okay, so the first question is, I always call it the elephant in the room. I am concerned about the side effects of biologic medications. What is the risk of cancer as a result of taking biologics?
So it's a great question. We've used the biologics for about 15 years. They came in about 1999, 2000. As you might recognize, they're blocking tumor necrosis factor, right? So that sounds, if you think about it, why are we blocking something that kills tumors, right? So it's always had this uneasy dimension of concern. The good news is, Dr. Laura, we have a chair for you here. See her quads as she's coming up. There have been two major concerns. One is cancer. So when the biologics first came in, it seemed like patients with rheumatoid arthritis and spondylitis were having lymphoma at a higher rate than expected. They were compared to the healthy population, but when they compared against rheumatoid and AS patients had equally severe disease, there was no signal for the biologic. It's called confounding by indication. We are actually comparing apples and oranges. So the consensus seems to be in the large databases that there's no significant increased risk of cancer with the long-term treatments. In fact, some cancers, prostate and colorectal cancer, seem to be actually down. Cardiovascular risk actually seems to be down. And the thinking there is that if you control inflammation in your body, this is not just in AS and rheumatoid arthritis, this is true in inflammatory bowel disease and psoriasis, that you're reestablishing a much more healthy body homeostasis or balance. With respect to infections, as you're aware, we always screen for tuberculosis and certain viral hepatitis infections. In our data, in our population here, we've surveyed to see whether the biologics in and of themselves increase a risk of infections, and the answer is no. So baseline screening seems to be a very good check. As you know, if you have an intercurrent infection while you're on a biologic and you're taking an antibiotic, we put that on hold. And then, so Richard, you have a question? Just to follow up, are the risks the same for IL-17 inhibitors? Yeah, so it's a good question. Richard's question is the IL-17 concern. So there's been a concern, for example, about fungal infections. Like if you look at the immunologists tell us that IL-17 is important for defense against fungal infections. So things like candidiasis in the mouth. So far, the signals have been fine, but we only have about 2 to 3 years of observation with the IL-17, specifically secukinumab. Whereas we got 15 years, well, almost 20 years with TNF. So far, the safety profile looks good with the 17 inhibitors. Next question.
Okay. Another biologic question for Dr. Haroon and Dr. Inman. If a biologic is stopped for 3 to 4 years or more because of symptoms, back pain, are relieved, what happens in terms of response if the biologic needs to be restarted after 3 or 4 years?
Yeah, it's a great question, and it's often asked in the clinic. We don't have a clear answer, but there is a theoretical possibility that when you have something external to the body introduced and it's taken away, it gives an opportunity for the body to fight back, right? Because we are introducing an immunosuppressant, our immunity is suppressed when the drug is being administered. You take the drug away, our immunity gets activated, and it tries to fight anything foreign. And what is foreign in the body is the drug that we are giving. So there is a theoretical possibility that our body will produce antibodies against the drug. So when you come in at a later time point with the same drug, either it could act at a big less effective, or the antibodies could cross-react and you can get reactions, allergic reactions. So there's a theoretical possibility. We've seen that happen, but not always.
Okay, thank you. This is a question probably for Dr. Flannery and Dr. Bartlett and Laura. Both Susan and Laura and Dr. Flannery recommended exercise being so important. But what should people do who are in too much pain to get out of bed, never mind exercise? So do one of you want to start it and hand it over?
So too much pain to get started. It's a very challenging question, absolutely. I usually try to frame things or reframe things. People do get up and do their function. So taking a history that elicits some of that function that's actually there demonstrates that although it feels like they cannot get out of bed, they actually do get out of bed and start. So pain is your enemy that destroys you, so really trying to make sure that they understand the concept that just continue to move is going to help them. It's going to, so, we used to say that, back pain many years ago, we said, people just stop and go rest. We found out that that was probably the worst thing we could have ever have told people to do. So that example shows how the deconditioning, do people have a sense of how quickly you become deconditioned if you stay in bed? Let's say you stay in bed for a week. How much muscle mass are you likely to lose? Anybody, just throw out a number. 0.5%? 50%. If you stay in bed for 1 week, 30 to 50%. So when you start to frame things around not moving, people then start to go, oh my God, now I get it. That's why rehab has been so effective at helping people get up, because our team, our interprofessional team, gets spinal cord injury patients up and mobilized, or brain injury patients up and mobilized, or stroke patients, all of those different health populations. Chronic pain is the same thing. Getting them up and moving is really one of the important aspects. So reframing to understand the consequences of not moving becomes a very good motivational aspect around that. And understanding then that there might be some methods, that's where the medications can be used proactively rather than reactively. So taking the medication to take away some of that pain to enable you to function. So that, again, a concept of reframing is one way that I use.
I would say that from the psychologist perspective, we follow that up with trying to understand with what the person is saying to themselves, because they're probably saying something like, I'm just going to give myself another easy day, and then I'll feel better tomorrow, and I'll feel more like doing it tomorrow. It's kind of Scarlett O'Hara. When the reality is, and this is assuming that the physicians have cleared you, the physiotherapist has said you should be moving, that what you need to be doing is fake it until you make it. So looking at what you're saying to yourself, and are you really helping yourself by saying these things, or are you staying stuck?
And I think to approaching activity in general, no matter what it is, it has to be gradual, but you have to stick to the plan. So there are days that you're going to feel great, where you're going to be able to jump out of bed and off you go, and chances are you're going to feel pretty awful the next day because you're not used to that level of activity. Then there's going to be days that you really have to push yourself. So that idea of that gradual introduction to activity is on the days you feel good, still stick to the plan. Only do that 30 minutes or whatever it is that you said you were going to do. The days that you feel bad, you got to push yourself to do those 30 minutes. And you just stick to the plan and keep going each day, one at a time.
Okay, so just building on that, actually, there's another question is, are there any videos or apps that you would recommend for exercise?
So actually, I've got 3 of the same question here.
Yay!
So there's all kinds of great online resources. So the CSA has great online resources with links to other organizations, with links to the Arthritis Society, which has a great new website with tons of resources. In terms of apps, there are a few apps out there specific to ankylosing spondylitis. They vary in terms of content and comprehensiveness. So some are very basic, others get into more detail in terms of exercises available. And again, in terms of technology, and I mentioned this in the talk, the idea of activity trackers can really be helpful in terms of monitoring your activity, setting goals, giving you reminders. Like even just, for example, if you have a sedentary job and just simply standing up and sitting back down so you're not sitting for hours on end, just set the timer so it goes off, or on your smartphone, so that, boom, it goes off every 30 minutes to remind you to go up, take a little walk, get a drink of water, and sit down. So it's the little things. Like, it doesn't have to be advanced technology. It can be very simple things. But online, there are a lot of good resources out there.
Sorry, that might be something that we can actually work together and kind of assess and put some more resources on our website.
Sorry. One of the things that was actually done by one of our previous fellows was he assessed the online literature that was available for ankylosing spondylitis. And he actually rated it in terms of literacy, accessibility. That was Ahmed's poster at ACR. So there have been some studies that have actually looked at content and quality of online work. So yeah, we can definitely work.
Just a follow-up question here on in terms of resources. So this is for Dr. Susan Bartlett. Could you list potential sources for counseling therapy, especially for students in low-income?
So the nice thing about students, if you're a university student, is that most universities, in fact all universities that I can think of in Canada, have counseling centres, and they offer counseling for their students at no cost. The other thing that's an incredible resource, especially if you're in a major metropolitan area like this, is you've got University of Toronto, York University. They have clinical psychology programs, social work programs, counseling psychology programs. A lot of students, and these students need training, and they have clinics that are available to the community. The clinics run on a sliding scale, so they will work with you to make sure that finances are never a barrier. And you get outstanding counseling, quite frankly, because the students are very carefully selected and they're closely monitored. But it's a great opportunity to be able to go in and sit down and talk with somebody and get treatment at a much reduced cost to going and seeing your average psychologist or social worker or counselor.
Perfect, thank you. Here's another one actually for you, Susan. What do you recommend people do whose loved one is clearly depressed and won't do anything?
That's really tough, and I know that you will get calls from time to time. We've talked about this before. You know, the thing is, it comes back to the communication that I talked about a little bit earlier, and it's frustrating. So you have to find a time, you have to find a space, but it's, I think, very important and very motivating to patients when their family members are honest. These are the changes I see in you. These are the things that we used to do that we don't do anymore. here are the things that I don't hear you saying before. You used to love this, 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 and this, and now the hockey games aren't of interest to you. So when family members are able to reflect that back to patients, that can often be the key that helps patients say, you're right. They may not know what to do about it, and so then again, you can be a real help by saying, let's see if we can find somebody that you might be able to talk to about this. And often it makes a world of difference if you'll just go to with the person to the appointment, to the first appointment, and sit down. It's just that little bit of energy and nudge and support that they need to follow through. Once you get them into someone like my office, we know what to do. But the huge barrier is getting them in and just making the contact.
Okay. Do you have other questions within your pile? Or?
Okay. Just a question here. Can AS affect the shoulder and the jaw? Certainly. We mentioned Achilles tendonitis. This disease has a propensity to inflame sites where tendons insert into bone. Right? So like around the heel, for example, and around the shoulder. All the tendons around the shoulder can become quite inflamed. We can see it on an MRI sometimes. Jaw involvement does occur. It's not that common in our clinic, but it certainly can occur. So the shoulder can sometimes, a local steroid injection can help, less so with the temporomandibular joint, but if they're both active, they kind of tell the rheumatologist we're not really on top of the game. We might have to change the treatment game plan. There was also a question about dyskinetic movement. That would be very unusual in our clinic. So if someone's experienced a dyskinetic, like movement disorder in the setting of spondylitis, we'd usually have them see a neurologist, right? So once in a while, there are neurological side effects with the biologics. They're very unusual, but we have a few patients in our clinic that have experienced some neurological side effects. So in a setting like that, we, as rheumatologists, we would ask for advice from the neurology team.
Okay, in looking at AS triggers in the research, what role does stress or traumatic events play? So I'm not sure who wants to try to address that.
Well, it's an interesting, one of the paradoxes of AS is that exercise and loading joints is a good thing, but there's some research that it might be too much of a good thing that might backfire. So there's some studies in experimental models that if you load an inflamed joint, it seems to be a little worse. There's also some work to suggest that patients with AS that have physically demanding jobs, so like car mechanics, electricians that are hyperextending or repeated manual lifting, if you compare those versus a less mechanically loading job, career path, it might have an adverse event. So I think what we're looking for is the right amount of exercise. As Laura said, it's got to be smart exercise. Whether trauma can actually trigger this event, this does come up in our clinic because somebody might have been relatively stable and they have slip and fall off a ladder at work, or they get rear-ended at a red light. And all of a sudden, a trauma, the injury to the spine seems to accelerate the trajectory of the disease. We don't really understand what that is. We think that in patients with AS, your immune system is sort of hyperactive, and it might be an infection, it might be an accident like trauma, but you have a hyper-reactive response to that. So there is some evidence, and I'm saying there may be people in this room who can look back at an event, an injury or an accident that seem to accelerate things. But we don't think it's really causative, but it might be accelerating.
So I'll just add to that. I have a very different take on stress and trauma when I hear those words. Stress, the kind of stress, psychological stress, is like throwing gasoline on everything. So the best predictor of when somebody's going to flare is when they're going through stress. So you need to become a good stress manager. That's really important. In terms of trauma, psychological trauma, there's growing evidence that one of the environmental switches, somebody was talking about this earlier, is trauma. Because a substantial number of people have experienced a major trauma in their life in the year prior to diagnosis. So we know that the mind is really important in terms of not only the onset of the disease, but also how things are going to go over time. Really important to get good at managing stress.
Okay. Dr. Flannery, how do you recommend handling a physician who will not prescribe pain medication? Sorry,
again,
that's a tough one.
Yeah, it is. I think. So, and we're running into a lot of this with opioid, recommendations to curb and stop opioids. It's just prevalent, and we actually lecture on how to do that tapering aspect or have the conversation. And the new Canadian guidelines that came out in 2017, which were the second set of guidelines, had a lot of additional information which we had gleaned because the first set of guidelines in Canada in 2010 by my former fellow and now rock star leader in chronic pain, Andrea Furlan, she established that there were some parameters that we could follow, and subsequent to that, research got better. And we could start to see, looking specifically at the causative effects of high dose of opioids, that there's a lot of problems. Opioid-induced hyperalgesia, suppression of the adrenal axis so that people can have suppressed gonadal effects, and people can have osteoporosis as a result of this because we're suppressing all their testosterone, men and women. So there's a whole bunch of things like sleep apnea syndrome. So the effects are great. The evidence, the guideline about the weaning part is actually only a weak recommendation. So it's very difficult. We're kind of in a clinical equipoise right now around how best to manage this group. We're getting more information. I think asking for a referral to a pain clinic that might be able to assess whether these are helpful or not, if it's from a family physician. If it's in a pain clinic, it might be worthwhile to have a second opinion to sort of make sure, because I think you do need an honest opinion as to whether or not the opioids are beneficial for this individual. And I would usually look at function, and that's what we try to encourage people to look at. If it's helping you and you're improving, not just your number going down, but improving you overall, that can be helpful. It's not dissimilar to what we do for the emotional aspect, is taking a reflective view. So those are a couple of suggestions that I might look at. Okay. Having an honest conversation with your family doctor is another thing to sort of say, what, are you worried about addiction? So there is a self-management tool that Dr. Furlan and one of our nurses worked on, a My Opioid Manager, which is available. It's an app that can look at some of the education around how to use opioids. So it gives you an idea to sort of say, are you using them in the most effective means, which might help with the education with the physician. But it is a very difficult and sensitive area, and people do feel as if they're under kind of siege around this push to just get everybody off opioids. And they can be really helpful in certain individuals, no two ways about it.
Thank you. I think Dr. Haroon was...
There is a follow-up question for Dr. Flannery. So just to put it in context, I presented the recommendations for management of ankylosing spondylitis. So we generally start with anti-inflammatories and then go on to biologics. And if the patients are still symptomatic, then generally we take the help of a pain clinic or a pain person. So what are the tools in your kit that can help manage pain in these patients?
So I think we talked a little bit about it, the 3 M's. So the medications are one. Looking at mood and how mood affects, and if there is some presence of some dysfunctional mood aspects, having it addressed. It doesn't always mean a medication, it just means maybe counseling, making them aware, and so on. And then the mood medications, and I'm blanking on my own third, the mindfulness that people have, because cognitive methods are very effective at assisting individuals. The meds, interventions can be quite effective. So we've, in the right individuals, spinal cord stimulators can be fantastic. And what are the right indications? When it's leg dominant pain as opposed to back dominant pain. So back surgery for back pain, a bad idea. Back surgery for leg pain, a very good idea. Back surgery or back stimulators for back pain, a bad idea. Back stimulators for leg pain, a good idea. So it prevents some of the neurologic consequences. So understanding that concept around some of these interventions are helpful. Sometimes the interventions like steroid injections, and Jill was asking me about that, do I do it? The SI joint's a very difficult area to get into, so now with ultrasound guidance we can get in much more effectively and make sure that it's not judged as a negative result because we actually didn't get into the SI joint. An ultrasound is a very easy tool to do as opposed to fluoroscopy, which involves a little bit of radiation. So there are different methods to manage the interventions, and we've got that whole gamut that we look at in our pain assessment.
Okay. Laura, what type of cardio do you suggest for somebody with extremely limited breathing due to no rib cage expansion?
So, it's a good question. Again, when it comes to cardiovascular exercise, it really has to do with your effort. So what moderate intensity for me, for example, might be different than Dr. Haroon. So, so I think it depends on the individual, and as long as you're getting your heart rate up to that target heart rate, then I think that you're going to be achieving cardiovascular fitness. And so, as I mentioned, one way of doing that is through the talk test. So if you're sweating but you're able to engage in a conversation, then you're likely working within a moderate intensity, which is around 70% of your maximal heart rate. Other things that you could do is wear like a heart rate monitor. Most equipment at gyms have sensors that will indicate your heart rate. So it really has to do with more your effort that is involved with the specific activity that you're engaging in, and that will then translate into cardiovascular fitness.
Okay.
Oh, I do have another question if you want to keep going.
Sure, go ahead.
I'm going to put these on. So the question is, this is related to the ball. How long should I sit on an exercise ball? So, as I mentioned, just simply sitting on a ball is going to improve core strength. So often, and this is good for people who are just starting to engage in exercise, I will suggest take the ball, get the ball, again, you want to sit on it with your hips and knees at a 90-degree angle, and watch TV for half an hour. And at commercials, although commercials are kind of a thing of the past now with Netflix, but you'll get the idea. So at commercial, do some leg lifts. So what you're doing is you're decreasing the base of support of the ball and you're wobbling a little bit more, and it's putting more, it requires more core strength to stabilize the ball while you lift up your legs. So, I mean, that's a very simple exercise that you could do, and that's like half an hour. Other people will actually just take the ball to work. They have sedentary jobs where they sit at a desk and sit on a ball for half an hour and then throw the ball in the corner, sit on a chair, and then alternate back and forth. Some people will sit on a ball for the whole day. But it really is an effective form of engaging the core. It works on your posture, and it's a pretty passive form of exercise, I suppose, if you're just starting to get into exercise. But it's very effective in terms of core strengthening.
You want to go?
Oh, sure. What are the biggest changes in ankylosing spondylitis in 3 different fields? One, diagnosis, treatment, and prognosis. So I can take diagnosis, you can take treatment and prognosis. So in terms of diagnosis, MRI was the biggest change that happened for ankylosing spondylitis. This was introduced in around 2007 or so. And since then, we have been able to pick up a lot of patients with inflammation in the spine and yet having a normal X-ray. So that is how the new classification and the totally new kind of diagnosis of non-radiographic axial SPA was introduced. Now, what we are realizing more recently is that the specificity of this MRI tool is not that great as we thought initially. So in 2007, we were probably overdiagnosing a few patients. Now we know that MRI, if you do MRI on 100 people walking on the street, 20 to 25 of those 100 people could have changes that look like ankylosing spondylitis. So we have to take changes in the MRI that we see in the MRI in context of the symptoms and the other investigations that we have. So just to be sure that we are not overdiagnosing and unnecessarily treating these patients with biologics. That's one of the major changes that have happened in diagnosis. For treatment?
So I'll take that question just and add a dimension with a related question. What AS factors result in changing from NSAIDs to biologics for an AS patient? And secondly, is starting earlier, now given the data that Dr. Haroon showed, starting earlier better? So first on the landscape, about 40% of the patients in our clinic are just on NSAIDs. They get NSAIDs and physiotherapy and exercise, and they're doing fine. So not everybody that has a diagnosis of AS is going to a biologic. So what is the usual dominant factor that moves the clinician, the rheumatologist, from the NSAIDs to the biologics? It's symptomatic control. So the cardinal features of AS being pain, stiffness, and fatigue. When those become unacceptable to the patient, and that's communicated, that we usually establish that contract relationship that we clearly want better symptomatic control. So usually that's the central domain. Now we do use adjunctive measures. We use inflammatory markers like sedimentation rate, CRP. We'll occasionally use a repeat MRI if we're not sure how much inflammation is present, but usually it's anchored in pain control. And the 35 or 40% of patients that are doing very well on NSAIDs, thank you very much, doing their exercises, we're happy with that. Now, the subtext in that question was, but you guys showed that the biologics delayed disease progression. So even in that group that seem to be symptomatically, are we missing an opportunity? Very astute question. So the current feeling is that if you looked at that grid that Dr. Haroon showed, remember, when the serial studies are followed, probably 75 or 80% of patients in those windows of observation do not progress. So we tend to really stratify looking at prognosis with simple markers. Is a patient a smoker? Yes, no. Is the sedimentation rate or the CRP up? Yes, no. Is there baseline damage? Are there already some bone spurs in the spine? If the answer to those three simple questions is no, the patient's in a very low probability of progression. And so we wouldn't think there'd be enough of a case to be made for starting a biologic for a patient whose symptoms are well controlled with NSAIDs. Now it changes over time. One of the reasons we see our patients every 6 months is that things do change. The disease kind of waxes and wanes, and that's one reason why we do randomized control studies, because there may be a spontaneous remission of a flare that we might attribute to a biologic. So it's, I think, a lot of the long-term relationship we feel fortunate to participate in this observational cohort is that we can modify. We always say, this is the assessment at this point in time. That might change 6 months from now, so let's stay in touch.
Okay, Dr. Haroon, what information do you have on stem cell therapy, and does it look like a promising form of therapy?
Yeah. So far, there is no data on stem cells in ankylosing spondylitis. Having said that, there are a number of studies in rheumatology in general. So essentially, the whole idea is that our immune system develops from the bone marrow. And maybe there is something wrong in the bone marrow cells that are giving rise to the immune system, which is going on to attack the body, the joints. So if you try to remove the bone marrow and replace it with a normal bone marrow, and hopefully the whole entire system can be changed. That's the whole idea behind it. And one area where this has worked in rheumatology is systemic sclerosis. And that's a condition where the skin progressively gets tighter, the lung gets tighter, and it becomes difficult to breathe. And it's entirely driven by a group of cells that cause this fibrosis. So maybe, in some of the trials, by changing the bone marrow with stem cells, this, to an extent, it has been reversed. There has been no such successful trial in ankylosing spondylitis. I'm not aware of any such attempts anywhere in the world as well.
Okay. I think we have time for just one more question, or maybe two, but is there any current research into the microbiome?
Microbiome.
Okay. Microbiome and AS. And then the second question to that is rehabilitation of the microbiome. Third question, how can we volunteer or participate in research studies?
The third one's easy. We're welcoming people anytime for a trial. The short answer, actually, we're not, right at this point in time, we're not enrolling in a next trial. But there are new biologics coming on the market, particularly the oral biologics. Sounds a lot more attractive than getting intravenous or subcutaneous. So there's a new class of drugs called the JAK inhibitors that are already on the market for rheumatoid arthritis. They're being assessed for AS. So that's one piece. With respect to the microbiome, so as I mentioned, there's a strong relationship between inflammatory bowel disease and ankylosing spondylitis. We have had patients that start off with a food poisoning episode that seems to be the trigger for the disease. Correspondingly, there have been a number of studies that actually look at the gut. The gut microbiome is looking at the bacterial population that populates our GI tract. Which, interesting, there are more cells there than are in our mammalian cells. We're sort of walking petri dishes, right? So it's a very complicated cellular environment with billions and billions of organisms. But our GI friends are trying to sort out what the relationship of the immune system is with this microbial population, what they call dysbiosis. So there are several studies going on that have addressed this question in AS, that maybe there's something wrong with the microbial population in the gut. Okay, there's supportive evidence. So what are we going to do about it? So in terms of repopulating the gut microbiome, on one extreme we have a disease called that's induced by Clostridium difficile. It's a pathogen it's very common in patients in the hospitals around Canada, where an organism takes over. What's called a fecal transplant, actually where you repopulate the gut with your own fecal bacteria, turns out to be quite an effective mechanism. Now those studies in inflammatory bowel disease, like Crohn's disease, have not been very effective. Could there be something a little more benign than a fecal transplant? It's kind of a weird concept if you get your head around that. For example, treating with antibiotics, or probiotics, or prebiotics. There's one study of probiotics from one of our colleagues in New Zealand that was negative. Anecdotally, we'll sometimes see patients that are taking ciprofloxacin for their Crohn's disease and their arthritis feels better. At the present time, there's no solid evidence that antibiotics really change the activity or the course of ankylosing spondylitis. Nevertheless, we're very interested we think there's a lot of important biological lessons. One of our graduate students found in the synovial fluid of patients with ankylosing spondylitis cells that actually started in the gut. So sometimes the T cells got educated in the gastrointestinal tract, and they ended up in an inflamed joint. Very interesting for an immunologist, right? So we think we're beginning to understand the microbiome better, but there's a long way to go.
Okay. And I think we have time for one more question. This is a common one that I get asked a lot, so I'm anxious to hear your answer. Do you ever combine two biologics in refractory disease? So
I'll start. Previously, it has been tried in multiple diseases, especially rheumatoid arthritis, where especially in the era where there were not many choices. Currently, there are many choices for rheumatoid arthritis. So people try to block two different molecules, so both immune stimulatory molecules, and the result was that because you're blocking two pathways that are important for our immune system, there was a significant increase in infections. So that was given up at that time. Now, especially in the field of ankylosing spondylitis, there is a promising combination available that we have tried and many people around the world have tried. There is a drug called Entyvio, which is specific for the gut. So it helps patients with inflammatory bowel disease. And the immunosuppression is quite gut-specific. It doesn't have a lot of systemic effects. Because it is gut-specific, it doesn't control the arthritis and the spinal arthritis and the peripheral arthritis. So we have started, in individuals where the gut doesn't respond to, for example, TNF inhibitor, we've started combining TNF for the joints and Entyvio for the gut. That's one of those rare situations where you can actually do the combination. There are thoughts around combining the oral drug, the kinase inhibitors, with an injectable drug, but I don't think there's a lot of data around it.
Yeah, I think that there are a couple of compounds that they're called DVDs, dual variable domain monoclonals, so they actually block TNF and IL-17. The trials in rheumatoid arthritis don't really look like they add much. They don't add much over, say, the TNF alone. But I think as we understand the biology of the disease better, we're going to get more targeted. And just on that point, we've gone through an interesting evolution in the biologics. So everybody got under the TNF-alpha umbrella. It was good for Crohn's disease, for psoriasis, for rheumatoid arthritis, for ankylosing spondylitis. It just looked like whatever you got, we can fix it, right? Not entirely true, but the next generation of biologics are quite different. So IL-17, which works very well for psoriatic arthritis and ankylosing spondylitis, doesn't work for Crohn's disease. Doesn't work very well for rheumatoid arthritis. That's interesting. If you block IL-23 instead of IL-17, it's dramatic for psoriasis. It doesn't work for ankylosing spondylitis, but it looks pretty good for Crohn's. So we're entering a very interesting, I think, the next generation of biologics have got the clinicians and the basic scientists really scratching their heads. Of course, we're all committed to making sure the right drug gets to the right patient at the right time. That question has got some very interesting nuances now, I think. But for sure, the next generation, it's going to be a challenge to customize treatment exactly for the patient. And that'll be good. That's called personalized medicine.
Okay, so I think given the time, we're going on to 8:40. We'll close it down. And there's a few questions that have been answered, and maybe you can come up and ask one of the speakers. I'll just quickly say on behalf of CSA, thank you very much to all the speakers for your presentations and your time to put everything together and traveling from Montreal. You know, you guys spoke, we listened, we brought in specialists in pain and mental health. We're continuing to do more of that, really populating our website with more information, as Dr. Bartlett has pointed out. Mental health is huge. I hear it every single day from people either emailing me or Facebook or whatever. So we're taking it really seriously because we really feel it is a huge factor in your overall improving your outcomes. So there's lots of good things happening at the CSA. Keep following us on the website, on Facebook, and we hope that what we're bringing to you can improve your outcomes and your quality of life. And again, thank you to you guys, and I will leave it to Dr. Inman to just say a few words.
Well, it's been great. I'd really like to thank John and Susan for it. Added a new dimension, and I think one that our patients wanted. Thank you very much. And I thank you all for coming and for your support. I think this is really a partnership between the healthcare professionals across the whole spectrum and the patients. And I think together we're going to win this.
Sorry.